Шановні колеги, партнери, друзі, давайте розпочнемо наш...
Colleagues, partners, friends, let's start our work and our meeting on the implementation of screening and early diagnostics of cervix cancer. Good to see everyone here. And I want to introduce myself, Andriy Skipalsky, the head of non-communicable diseases of the WHO office in Ukraine. I'll be here with Halina Maistruk moderating this discussion. And so some organizational rules of our work. You can see our agenda and you can see our detailed tasks. So we have to try to meet the timelines and engage you to discuss the problematic issues. We have simultaneous interpretation available, so when our international speakers say something in English, feel free to use interpretation. You have the headsets. So you can see that the meeting is structured. We will have coffee break and lunchtime. We'll have a chance to talk to each other, exchange opinions in less formal environment. So now I'd like to give the floor to our dear speakers from different institutions. Valeria Soruchan, Serhiy Laponokh, if he's here, from NHSU, Tetiana Arabina, and Halina Maistruk. So please join us here, and we need to formalize this process and start from the welcoming words, and we'll get down to business. So, I invite Valeria Soruchan, the head of the Primary Healthcare Emergency Care and Disaster Medicine of the Department of Health of the Ministry of Health. So, Valeria, over to you. Dear colleagues and medical community, organizers, representatives of the World Health Organization, I am so glad to welcome all of you here on behalf of the Ministry of Health. We're so happy that both you and us have, both you and we have this opportunity to discuss all the topics related to screening and early diagnosis of cervix cancer. Taking advantage of this opportunity, I'd like to congratulate everyone on behalf of the Ministry of Health with the upcoming Day of the Healthcare Worker. I want to wish all of us health, patience, and inspiration. And of course, this topic is being discussed a few times a day. I want to wish all of us the fastest victory for all our defenders, men, sons, brothers, to come back home as soon as possible, and for families to get reunited. Now about our topic today. I would like to say one point. Back in 2024, we all know that the national strategy of control was made, of control of cancer, oncological diseases, and goal number 3 was the following: early detection of oncological diseases. And according to that, we developed and approved 2 main documents that we have: Order 1368, which stipulates the order of screening and early diagnosis, and also Order 1057, the standard of medical care provision. And in this regard, I'd like to say that as of today, these regulatory documents helped the state create all the possible mechanisms for us to run the primary secondary prevention according to the Order 1368. Primary and secondary prevention is provided by the primary health care providers, and it is in alignment with Order 504 about the order of primary health care provision. I mean, we covered this point. We have all the tools. We have to implement all of that. It's also important to say that from January the 1st, 2026, from the state budget on the national level, there will be a chance to provide HPV vaccination. So, of course, that treatment will be provided in the specialized institutions, but the prevention will be available. We have all the resources and tools to make that happen. And in this meeting, probably we won't be able to discuss all the issues and points and challenges that we face. But in this technical meeting, we'll be able to solve some problems and discuss the challenges we face on the primary healthcare level. So I wish all of you to stay in a good mood and have a fruitful day. Thank you. It's important to hear that the ministry continues implementing the strategy, and in this discussion we will talk a lot about such foundational documents, orders, regulations, which make this activity possible and provide the impetus and regulate a lot of areas. So I'd like to introduce Jarno Habicht, the representative of the WHO office in Ukraine. He has his welcoming words in recording. So please start the video. Jarno?
And partners.
Чекайте, ми не бачимо.
Wait up, we cannot see anything.
Будемо ще раз.
Let's start all over again.
And partners. Доброго ранку. I'm pleased to welcome you to this final meeting on implementing the cervical cancer screening and early diagnosis system in Ukraine. According to the International Agency for Research on Cancer, Ukraine has over 20 million women aged 15 and older who are at a risk for cervical cancer. Each year, 4,756 women are diagnosed with a cervical cancer, and over 2,000 die from it. Cervical cancer is the fourth most common cancer among women in Ukraine and the second most common cancer among women aged 15 to 44. According to the WHO statistics, 5 in 10 women have been screened for cervical cancer in the past 5 years. Screening, access to quality medical services, and HPV vaccination are the key evidence-based interventions that could lead towards cervical cancer elimination. Ukraine has made valid progress in regulating and establishing screening programs over the last years, with adoption of a new standard of medical care for cervical cancer screening, management of patients with abnormal screening results, and precancerous conditions of the cervix. The screening is integrated into the program of medical guarantees and is now mandated by National Strategy on Cancer Control. The recent introduction of the HPV vaccine into the national immunization program opens new opportunities to curb the disease. The WHO Global Strategy for Elimination of Cervical Cancer sets clear targets for 2030. First, 90% of girls fully vaccinated with the HPV vaccine by age 15. Second, 70% of women screened with the high-performance test by age 35 and again at the age 45. And third, 90% of women identified with a cervical disease receiving appropriate treatment. WHO supports Ukraine to achieve the goal 90, 70, 90 targets for eliminating cervical cancer as a public health issue by 2030 to save more lives. Today, you will receive the results of the cervical cancer screening project implemented over the past 6 months in several communities of Cherkasy Oblast. The project results will highlight the main achievements and identify the next steps to strengthen screening programs. Cervical cancer screening and the early diagnosis are not just health goals. It is also a key to Ukraine's continued progress and successes. I would like to thank the Minister of Health of Ukraine, the National Health Service of Ukraine, the Department of Health of Cherkasy Oblast, and all partners for their strong commitment and collaboration on this project. I hope this meeting will be a turning point in aligning our actions and moving forward in cervical cancer screening in Ukraine. I wish you a productive meeting. Thank you. Дякую.
We heard the welcoming speech from the representative of the WHO office in Ukraine, and please pay attention to the fact that the aim of our discussion will get down to getting the progress in the area of elimination of cervix cancer. So that's been just said. And I'd like to give the floor to Serhiy Laponokh, Deputy Head of NHSU. Serhiy, over to you for the welcoming words. Hello, everyone. Congrats on the upcoming holidays on behalf of the NHSU. And I wish all of you strength and high spirit, and I want to express gratitude to our defenders and healthcare workers, thanks to whom we are here today. Going back to the context of the meeting, I'd like to divide this topic into a few points and to dive deep in the discussion. So in 2024, after the analytical work related to the health providers in oncological field, we understood that the main track of 2025 for sure will be related to oncology. That's why we are here working on two types of monitoring, planned and out of planned monitoring, and we finished the stage of the plan of the monitoring, and also we are working on the out of plan monitoring. Now, related to the absence of the medicines and other consumables, we will not speak about that, but at this point we are building the monitoring processes in a way that unfortunately we run the audit if the facilities have the necessary staff and equipment, and that's important to understand who has what in this monitoring. And out of plan activity also is helpful. We need to understand whether antibacterial medications are also available. Also, I'd like to say that the last publication was published in the UK. It is more related to the analysis and analytics of 17 countries of Northern Africa, and over there the number of cases of cervix cancer is increased among women of reproductive age. And there is one more factor, that is the global climate change and increased temperature, which is a contributing factor to a theological component of cervix cancer. Now about the focal area, I'd like to say that we register all the proposals from service providers on the expansion of diagnostics tools and opportunities, and introduction of the new codes in the chemical testings. But I think that in the panel discussion, Yevhen Horokh will outline in detail different points that we face, and we clearly understand that the area of our work is like that, and of course we need to dive deep into the clinical areas, and we need to join you to our monitoring missions. We need to unite our efforts with the representatives of MOH. So I'd like to say that we are open to move forward. We are open to face the changes so that we would succeed both on the primary healthcare level and specialized healthcare level, diving deeper into the clinical aspects. Thank you for your attention. Have a fruitful day and all the best to you. Thank you, Serhiy. Probably as the representative of NHSU, you're used to the fact that there are a lot of questions to you and attention, and within the implementation of this project, NHSU together with MOH and the Department of Health, you are always working in the area of how, what, and with whom needs to be done. So please take advantage of this opportunity during the coffee break to have the discussion with Serhiy, Yevhen. There will be a panel discussion and the speech where we will try to learn more about the program of medical guarantees. Thank you for your statement, and I'd like to give the floor to Tatiana Rabina, Deputy Head of the Center of Public Health Center of the Ministry of Health. Thank you for the cooperation in this project. You developed a lot of areas, and health promotion and population awareness is an important component in this regard. Tatiana, over to you. Thank you, colleagues. Thank you for your engagement and for this emphasis on this topic. As of today, it can't fully be discussed. The topic that we will discuss today, the whole day, is not just politically important. Actually, it may be a problem of any family. The enemy impacts our emotional condition, but likewise, any disease for any family which can face, it may become a tragedy for that family. So our country doesn't have a lot of resources to cover in general, to cover fully the treatment, and first of all, the treatment of cancer and oncological diseases, because any country that allocates budget understands that it's enormous costs for the country and each family in particular. So speaking about the prevention of cervix cancer, speaking about the stage of the implementation of screening into the program of medical guarantees into the health policy, that's important to discuss. It is way cheaper to put effort into prevention, and the results that both the population and the country and politicians may get, they are way bigger than the costs that the country may have due to the treatment. Anyway, we say that the incidence every year goes up, and it's really important that last year became a turning point in this regard, when on the national level we discussed the relevance of screening of cervix cancer. 2024 became for Ukraine the year of prevention of oncological diseases. A few strategic documents were adopted and passed, and as a country that in 30 years in the context of political priorities, we didn't have the priority of cervix cancer, and we finally got the opportunity to focus on that, and in 2025 we rapidly started implementing different tasks, and I hope that this way we'll try to take some steps to conquer this horrible disease. As a country, as Ukraine, for the first time we become the full member of the European society community that actively moves in the area of screening and cervix cancer elimination. We showcase over the last year, we've shown by leaps and bounds we moved in this regard, because a lot of historical decisions were made, starting from the president's decree that implemented the decision of the Security Council, all the way down to the regulatory changes which were implemented related to the access and the mandatory screening of cervix cancer on the primary healthcare level. So I do believe that all the efforts, both that you put and we put, politicians put, and the prevention efforts of people who work in the facilities, who study the barriers towards screenings, who are trying to optimize any processes and results in this regard. All of that will make it possible to achieve joint efforts and to conquer this horrible disease. So thank you for being here with us, that we're partners in this regard, and we move forward. Thanks.
Ms. Tatiana, thank you so much. Thank you for the support, and thank you for supporting the PHC. And I pass the floor to our next speaker, Halina Maistruk, Executive Director of the Charity Fund, Women's Health and Family Planning. So her team actually took the commitment 5 months ago to go to the fields and, to do some field work and to understand how screenings may look like in real life, what are the problems, and actually study that thoroughly. So Halina, please. So thank you so much, Andriy. Thank you, first of all. Congrats. This is like a traditional holiday. As long as I remember myself, as a doctor professionally, we've always had that holiday. This is a very special one because medics currently in this current environment are playing fantastic roles. They're saving people's lives, both at front, beyond the front line, and people living in horrible conditions and very severe conditions. And I want to say that this is truly a very specific, special holiday. But today I'm so glad that we have this technical meeting and this discussion. This is not like a big conference, well, it was planned. It's not like a conference, very demonstrative conference, something declarative, but this is a serious talk. It's a platform where we actually can reflect, as experts and make some conclusions. So I represent in Ukraine, our organization represents, we are the members of International Family Planning Organization, a huge global organization that is taking care of women's health as well. And in this segment, prevention, cancer prevention, in this segment we've been for more than 30 years, I can say. And we cooperate with initiatives on breast cancer. We were the first one who actually were introducing these initiatives. We were creating programs, charity programs with business, like with Avon, Pink Ribbon, and many, many things that we were working on. And I just want to tell you that. So cervical cancer. This is my personal commitment. I can say that the commitment, and we have it now everywhere. Like we've had it many, many years ago, but it comes to the surface now. Ukraine has been for a long time in the zone of complete illusion that someday an effective screening system was established, in the late 70s. It was functioning, and people believed that system was so substantial, that it was functional, that it will just move forward. You just need to help it a little bit, push it a little bit, upgrade it a little bit, and it's going to work like that. It's going to function. So there is a foundation, but many, many things change. The world is changing. Circumstances are changing. When it comes to labor resources, attitudes, people, healthcare as it is, the structure, the framework of healthcare. And we are a little bit late, not even a little bit late. We are lagging behind, seriously. And why am I so happy still? Because we may be very slow, but I think we will manage to have some progress. Because judging with what we have now, and in a year, we've practically covered all the issues related to, let's say, regulatory issues, So in a package, these were introduced. Many, many issues were closed with a package that we hadn't had before. And this field work, Cherkasy fields are the best, I can tell you instantly. And this is a great experience. This is definitely an experience that enriched all of us as partners, and of course the WHO Bureau in Ukraine. And I do hope that it enriched those people who work directly in Cherkasy region, locally. It's quite an open experience, pretty raw experience. People are so open to dialogue. They're ready to communicate. And it's not a punitive thing. Nobody was giving orders. Nobody was like coming and inspecting, oh, you did that wrong, and so on. No. People are so open completely. What I was amazed with, and we will introduce that experience today, huge colossal potential is there. This is... I tell, I have experience working in many countries, and I'm very open and sincere with that. Huge potential there is, a lot of motivation. People are so motivated, and the issue that we have now, and what gives me optimism, what helps me to know that we will still be there despite being slow in the beginning. A lot is done already, and a lot of accomplishments, we have to push them forward in future, you know? And time is changing. Communication technology is changing. We will talk about this as well, which actually improves, gives us more chances to have better awareness raising campaigns, you know? And I'm so immensely grateful, first of all, to WHO Bureau in Ukraine. Thank you for giving this opportunity to us. Even these 5 months, you know, that we had, these were very turbulent and intense, I can say, but these are wonderful. I can instantly say that, because these are the opportunities, like, this was the opportunity to meet so many people, like a whole layer, social layer, different people. And this is very creative. And I'm so grateful to Ministry of Health for being open and cooperative. Thank you for this opportunity to give an advice, you know, participation of everyone. Thank you for being engaged. And I want to express gratitude to Ms. Tetiana Rabina. This is some titanic efforts there were. You did a very heroic work, you know, the whole design, how you were like actually designing that. You were one of the locomotives of the process, and this is something real. This is what I'm talking about. So I truly hope that we'll have some fruitful cooperation today. Not only today, thank you. Despite this turbulent situation, especially in Cherkasy region, thank you. We know what happened this night, you know, like, unfortunately, but we can see you here. You're beautiful, you're healthy, you're sane, safe and sound, and enthusiastic, and I really want us to stay enthusiastic till the end of the day. Thank you so much. Ms. Halina, thank you for very motivating, inspiring words. We will try to move forward with the same pace, fast and furious, so just words of gratitude, just some positive reflections when it comes to introductory words, and it actually inspires us for further work. Okay, just to finish with this blog, just a couple of words. Dean Cairns, head of WHO Bureau programs. So Jarno was, we had his video. We have the leaders of WHO here present with us. It only shows how motivated we are and how much respect is paid to everyone discussing this today.
And I'll be super quick because I think the passion and drive that's already been expressed by my friends and colleagues here have been fantastic, and I want to make sure that we're building on that for really fruitful discussions today. But really happy to see some familiar faces here today, and really happy to see a lot of friends here in the room as well, and a big thank you to MOH UPHC and also NHSU, and yeah, very much yourself for coming along and supporting all this work along the way as well. So today I also wanted to say very much a big welcome as well, just following up from Jana's words, but also to say that we wish you all the best for this Sunday and the coming days for celebrating International Medical Professionals Day. I think it's a really important day that we take the time to reflect, to celebrate ourselves, to celebrate you, because there's no other country in the world that medical professionals are dealing with so much at this time. And I think this is reflected and seen in terms of the support that the world is bringing to Ukraine, but in terms of also that time that we need to recognise that health professionals in Ukraine are risking their lives on a daily basis, as mentioned by a number of the panelists already, in terms of saving lives, keeping facilities open, providing services. But then at the same time, we're also providing the next generation with answers and solutions in terms of how we're going to be changing the institutions to meet the goals of this current reality that we are in. If that is in terms of changing health systems, if that's in terms of changing EU accession processes, all these areas are critical for the future of this country. And so the medical professions are such a critical part of this story. So I just want to say thank you to you all, and are very much looking forward to the discussion today. I'm already seeing the passion, the drive, and please challenging, open discussions about what we can do to further cervical cancer in this country. I think it's very, very important. So big thank you and big welcome again. Thanks very much.
Thank you, Dean.
Thank you, Dean. And this project is funded by the European Commission, which actually gives us a chance to tell that we're moving with this project in the form of European integration. We're paving the way as well to the future. So this is the final meeting within this short project, but this is the initial meeting for us to meet in a year and speak of elimination of the cervical cancer. Okay, we step into another panel. We just changed the disposition. We'll have some presentations now, and that's how we do it now. We have so many different speakers today. We will hear about some positive experiences, barriers, of course, reality of implementing the cancer screening programs. We have 2 sessions, then we have coffee break. So the session number 1 is introductory. We will speak about legislation, like what is actually regulating our actions and functions. So while we're discussing the cervical cancer screening program. So I invite Ms. Tetiana Rabina, Deputy Director General of PHC MOH. Please, you may pick the place where it's more comfortable. Thank you so much, colleagues. Yeah, it works. It's fine. Yeah, the sound is on. Okay, my presentation, I would love to visualize, use it as visualization for our today's meeting, just to mention the key regulatory aspects, which are the foundation for us in any decision-making process when we talk about screening and its introduction in routine practice for any doctor. And I would like to start with, may we have the next slide? Who owns the clicker? Who who rules that? You know, it's the most important person at any conference anyway. Great. So that's why we will talk, so what is basically the reason for us to have this meeting today and how the approaches are changing to these issues at the level of the country. Okay, since January 1st, 2025, a new MOH order has come into effect, 1368, that we've actually mentioned today, and it is dedicated to introducing the early detection and screening for selected types of cancer, monitoring the health condition of patients from the risk group. With this order, what it tells actually, there's a clinical route for a patient, for a woman who's a patient for the screening studies with a focus on a primary level. It contains it contains some algorithms for the PHC level screening and 2 other screenings. Also the colorectal and breast cancer are there as well. These algorithms are there. This is like the first visualization, basically the first attempt of MOH to put everything in one order. The clinical route and also other aspects. So designing local, regional, clinical routes also at the level of each region. So it's much more simplified with that. So we use this package or cluster approach. With the team of MOH, we tried to have this regional dialogue, to make sure that this clinical route is super simplified for patient and for this be super effective. Since January 1st, since November 1st, there's a mistake, I'm sorry, it's 2024. Yeah, we also made some amendments, 1834 order to the regulation of primary health care provision, and this problem that we had at the level of primary health care, we had 3 screenings where the also other type of cancer was included, and there were many discussions in the oncological community. And there were certain problems with interpreting the results and whether it's feasible to spend resources, limited resources at PHC for that type of screening, which actually wasn't 100% evidence-based in that way as it was implemented. So we made a decision to have a replacement. We replaced that. Not to get any substantial global changes, but this replacement, the substitution was absolutely justified. It was fully evidence-based and in the list of screenings that we have at the PHC level. So we actually introduced the cervical cancer screening there as well. So on June 18th, 2024, a little bit earlier, prior to these documents that I mentioned, 1057 order introduced the standard for the cervical cancer screening, how to handle patients with abnormal and pre-cancer conditions. So the group of experts was working for more than a year designing the standard. And this standard actually describes the algorithm of handling patients with abnormal screening results. And I want to focus your attention now, ladies and gentlemen. What is mentioned in the standard? What is there? So it's dedicated to mostly to clinical aspects are there, and patients, those ladies, if there's any justification to assume that these ladies have high risk of cervical cancer, with focus on some complicated history, or any other reasons to put the patient in that risk group. And the standard is itself is one that mostly focuses on oncogynecologist activity or oncologist activity. So this is more like a description of a clinical component to actually support the process. This is basically it. All these documents fully fall under the stages of cancer combating plan and strategy that we have, and also the implementation of the strategy for 2024-2025. So the next stage and the next plan is still in the process of designing, and as far as I understand, some other measures that will allow us to push all that forward, all the steps that we've taken in 2024-2025. So this will be reflected in the new plan of cancer fighting plan. Okay, cervical cancer. Okay, this is the 4th prevalent type of cancer among women in Europe, and so what place it takes? Like it has been there in this at this position for like dozens of years. So European Union has its own strategy to tackle cancers, various types of cancers, and we're moving basically with the same pace like the EU to protect our own population and help our own population, and to avoid these catastrophic expenses while we're tackling these horrible diseases. But the Ukrainian statistics, unfortunately, tells us clearly that so far we're not controlling the process, we're not leading it. 3,000 new cases of cervical cancer are registered annually, and more than 1,500 women, unfortunately, die with the severe stage of that disease. Screening allows to detect pre-cancer and early cancer types and to minimize the mortality and increases the level of treatment effectiveness. So we will talk to you today, and what I want to focus on right now. Mostly we will talk about introduction of population screening, implementing population screening with focus on, let's say, with focus on healthy women. Let's put them quote, quote, healthy, for whom age is the risk factor, if we speak about that screening specifically. So what is mentioned in the order? So the key messages basically that I want to tell you now is that women aged 21-35, if any other risk factors are present apart from age, or if they have cervical cancer symptoms, they have to be subject to screening every 5 years. Okay, women from 30 to 35 or 35 to 55, 3 cohorts are there basically. So by 35, by 45, by 55, so 3 cohorts. Every 10 years, screening is obligatory for them. Women living with HIV, AIDS, aged under 25, every 5 years they have to undergo the screening as well, because the risk of cervical cancer, they have higher risk, of course. And certain risk factors establish certain periodicity for screenings. The first stage for any screening introduction is the survey, to basically understand if the woman falls under a certain risk group. And here we speak about the PHC doctors. Okay, so when we had professional expert discussions last year, we mentioned that each region has its specificity, of course, its peculiarities to introduce that kind of screening program eventually. And for each region, of course, taking into account the financial capacity and technical capacity. So what we've identified, what we've concluded, that the order will not have any substantial limitations, but will simply allow to each region to introduce its own regional route and to identify, depending on what the traditional practice is there, what already has been there like for years, for each region to identify which type of test they will use. PEP test and PCR test are available and may be used for screenings.
Of course, the WHO management, the WHO guidelines, which was the foundation for this order, I can tell you that all our actions were agreed with the experts of the WHO office in Europe and in Ukraine, and agreeing all the actions, we made the conscious decision to keep this possibility to run this testing, I mean the pap smear test and PCR test. Of course, the use of PCR test in this regard is the better thing to do, is the right thing to do in the context of population screening. Here we speak about the reason that in 95% of the cases, if the woman has HPV, then the best way, the best method to detect the virus HPV in the woman is the HPV testing. But taking into account that different regions have different resources, we still have this option which enables to choose which way they want to choose. The risk factors. There are 3 groups. This order, it has 3 groups of risks: medical, behavioral, and social. I'm not going to dive deep into them. You all know well about these risks, and most other types of cancer, they also have the same risk groups. The only particularity related to this cervical cancer is the behavioral factor that significantly impact the risk, that is the early onset of sexual life and early pregnancy. As I earlier said, the general female age is the risk factor to run the population screening. And here we can see this point of the order. So what else is in the order? What algorithm of screening research is there? First of all, the woman has to make an appointment with the GP or family doctor via e-health system. That's possible to do that. Then the doctor explains that it's important to regularly do that screening. Then the examination and testing, you all know well about it. We will probably separately discuss the possibilities and the barriers to conduct this screening on PHC level and all the areas of interaction between different levels of healthcare provision. And the last stage is the interpretation of test results. That is really important because we understand that any test leads to the period where the woman waits for the results, and it's important. And it means that this research, this test has to be done in a quality way, and it has to provide reliable results because that'll impact next steps and the emotional condition and mental health condition of the woman and the necessary actions the woman will take. So of course, if the woman gets this result timely and if the tests were done in a quality way and if there is a chance to run differential diagnosis or repeated diagnosis if it's necessary for the diagnosis, it's important, but anyway, it's described in the other documents. So if the woman gets the negative result after the test, then the woman can repeat this test in 5-10 years, depending on the lifestyle and risk factors. If the test result is positive, then of course the woman is referred to a specialist to identify next steps and to manage this case. What should the doctor do? What should the family doctor do so that this contact this match with the patient and the importance of the screening test, so that the woman would understand this importance. Well, anyway, we do not fully impact the decision the woman makes, but anyway, to engage the patient into this screening, we need to raise the awareness of the patient, inform about the importance of screening, and jointly Public Health Center also disseminates this information material, simplifies them so that they would be easy to understand and easy to perceive. And the partners of the project, Charity Foundation, Health of the Woman and Family Planning, also developed the information materials, and they will be soon posted on the website of PHC, and part of the materials has been already published. So like these simple materials can be used for communication, because of course it simplifies information delivery, it doesn't take that much time, and easy to understand language helps the patient get educated. Risk assessment and identification of patients who need the screening, then preparation for the test, consultation related to the preparation, all of that is important, and that may impact the reliability of the results. And of course, the test itself. There are a lot of different options to organize this test and sampling, and the results of the pilot project in Cherkasy region will help us develop and the pathway and make the decision what pathway is the most optimal. The screening results need interpretation. I said that the test results may be positive or negative, and that will show what next steps have to be made by the patient and what support the patient needs to get. The state has taken an important step. For the first time in the wartime, the vaccination schedule was changed. That is a highly important event. You have no idea how much effort experts put to convince everyone that it's necessary to vaccinate against HPV. So all the resources are aimed at defense in our country, defense against the enemy. And here the state for the first time takes responsibilities and makes it possible to defend women against human papillomavirus. So the first consignment of the vaccines is basically procured, and I hope that it will be supplied late November or December in Ukraine. I get it that the cohort of those who will require mandatory vaccination and who will have the access to the free of charge vaccine, that's not a big group of people, only girls. For now, vaccination schedule doesn't cover boys. We understand that it makes sense that vaccination is provided to boys. This vaccination is recommended to boys, and parents can vaccinate their boys with out-of-pocket money. But the priority of the small resources, financial resources we have in the state was aimed at the group that will help us achieve maximum result. It wasn't an easy discussion to identify the category of those who will need HPV vaccination and who will have free of charge HPV vaccination. But for now, the decision is the following, that girls in the age group 12-13 and starting from January the 1st, this vaccination will be available. We understand that people have very, very good attitude towards this HPV vaccination. And the regions which procure this vaccine from own budget, for example, the city of Kyiv, they have a huge waiting list of patients. It is in huge demand, and the number of doses that the Department of Health of Kyiv can procure is about 20,000 HPV doses. It will take about 2 weeks for healthcare facilities to vaccinate everyone who wants to get vaccinated, and the waiting list for next year will still be there. So it is like all about huge demand. So the start of this vaccination campaign will be very successful. I hope so. And in the future, will make it possible that in 2027, more and more girls will get this highly important vaccine. Feel free to ask questions if you have them. Probably down the road there will be a panel discussion and there will be more questions, but any regulatory act will be just a paper if it doesn't get efforts from experts and if it's not relying on the opinions of doctors. Because doctors concentrate, they have this huge responsibility of implementation of all of that. So if there is no understanding why different decrees orders are issued, if there is no understanding that the ministry did something but doctors think that they know better what should be done, then any order will just be a paper and it's not gonna work. I'm absolutely convinced that what we will discuss in the meetings in Cherkasy region, like in the meetings with doctors, like the results of these meetings show that we've done great job, which is relevant, and I do hope that this step will make it possible for our country to become to get on the same level with other progressive European countries towards the elimination of cervical cancer. Thank you. Thank you, Tetiana. So we have 20-minute Q&A session, and after the session with the presentation of Cherkasy experience, because Cherkasy experience will show how these regulatory acts have to be put into practice. So it's my great honor to invite Antonina Humanets. She's the head of the Department of Health, and thank you for this work in the health sector. So we're trying to cover all the points of the project, and we have 10-minute presentation. Please outline the general directions and messages so that the participants would have a chance to ask questions. So the time management is really important, and each speaker has 10 minutes for a presentation. Antonina, the floor is yours. Good morning, colleagues. I'd like to thank for this opportunity to work and start the pilot project. I want to thank Tetiana because she was the first person to call and offer this to be done in Cherkasy region. Andriy, thank you. Ministry of Health, thank you. This is really positive experience for us, and let me tell you why. Experts highlight our gaps, our drawbacks, but at the same time no one scolds us, but they help us understand how we can improve and do our work better in the region. So I want to thank everyone, and I do hope that it will bring positive results for us as the medical community. Well, this is the second point. Well, the first point, I hope that it'll help our women who are really brave these days. But anyway, our women may have some weaknesses which lead to horrible results. So I would like to show you our elaborations, the pilot project on early diagnostics and cervical cancer screening, which was conducted in Cherkasy region. From March 2025, we implemented the pilot project on early diagnostics and screening, and it's been implemented thanks to the charity foundation Health of the Woman and Family Planning in coordination of with the MOH and the support of the WHO office in Ukraine. February 26th, the memorandum between the Department of Health and Charity Foundation Health of the Woman was signed, and it stipulated a lot of actions on screening and early diagnosis of cervical cancer in Cherkasy region. For the coordination and the support of this project, the order of the Department of Health created the intersectoral working group, which included the primary healthcare workers and specialized workers, also the specialists of the Department of Health and PHC and the Charity Foundation, Health of the Woman and Family Planning. Over the period of the project, we've had 4 meetings of the working group. Within the project, there were a lot of trainings for the healthcare workers of health facilities providing primary health care. I'd like to say that here, the top management of primary healthcare facilities and specialists and nurses, well, everyone participated in these meetings, and a lot of work was done and a lot of discussions took place there. At first, there was a lot of resistance, negative discussions, but we ended up with positive discussions. As a result of the work done, the project order of health was created, and it regulates organizational activities of screening and early diagnosis. The document stipulated 4 regional clinical pathways in the healthcare facilities and different types of facilities and their capacities were stipulated. Also, the early diagnosis and screening order was stipulated, and also the facilities were stipulated which will conduct PCR, cytological, HPV tests, and apart from that, the heads of the facilities, they had to develop their own clinical pathway of the patient, which stipulates the provision of healthcare to ensure timely cervical cancer screening, diagnostics, and treatment following the normal results of screening and pre-cancer conditions. Also, we worked on the update of all the centers of primary health care on how to take the samples for the early cervical cancer diagnostics, and also we've planned to communicate with the heads of the territorial communities of the regions which control the centers of healthcare centers, and also we created the necessary conditions for the cervical cancer screenings and provided the facilities with the consumables. Here you can see 4 roads, and the first pathway is the primary healthcare facilities which cannot take the material for cervical cancer screening, but in the last meeting we agreed that this pathway will be still active by New Year, because by New Year we agreed that in the region all the healthcare facilities will have a chance to take the necessary testing material for the cervical cancer screening. Here you can see the details, step-by-step details, like the age of the patients who need to be screened and how the doctor has to work, where the doctor has to refer the patient down the road. The second pathway is related to primary healthcare facilities which can take the necessary materials for cervical cancer screening, and here you can see the details. The third pathway is for the healthcare facilities providing specialized healthcare services, but they do not have the possibility to run the testing of the material. So here you can see the referral pathways. And the fourth pathway is for the healthcare facilities which provide specialized care and can provide the test for cervical cancer and can test the material. So here the facility can help the patient from step 1 all the way to the end. And of course, there were a lot of challenges our working group faced in the implementation of the project. First of all, the first challenge is that we had to run the detailed monitoring of the primary healthcare sector, and we understood that a lot of facilities have no chance to run this screening because there were no obstetricians due to the job cuts, and there were no gynecological equipment like gynecological chairs, and there is a lot of work to be done. And also they couldn't track the referral of the patients at first, and they used one health system to do that. Also, the next challenge is the sensitive data of the patient and medical records that have to be stored in a special way, and the access in the e-health system is quite specific. Actually, family doctors do not have the access to this data, even if the patient was referred, and by them they cannot track if the patient got the necessary tests or not.
So, and due to that, it's really more complicated to monitor the health condition of the patient subject to screening for oncological diseases. Therefore, I think that it's feasible to present some amendments to MIS to ensure that the family doctor has access to the serological test results, or HPV testing to assess the results, to control the process, and to ensure that there is a feedback and interaction with the patient, let's say, to ensure that there's a referral within the necessary clinical route. Okay, we've already sent letters to the heads of our communities, and we have 66 of those. So we've informed them. I think that we'll do everything and we'll help them to transform this activity, to transform the structure, and to make sure that they at least have like gynecological chairs and various materials they need, equipment, at least by the end of the year. We already have some HCFs that we've identified as those who can ensure some HPV tests. So we will try to design the routes, and basically that's it for me for now. Thank you so much. Thank you, Miss Antonina. Thank you for your personal motivation and engagement. And I think that routes, as we will actually use these as examples and distribute it. People are taking photos, by the way, and this whole experience will at least be comprised when the presentation. Will distribute that, and we hope that we will cooperate in future as well for HPV systemic screening to become a routine, to make sure that we simplify the process. Okay, I introduce the next speaker, Ms. Katarina Hetalo. She is the MO expert of Charity Fund Women's Health and Family Planning. She will introduce the project from the standpoint of data and results. Ms. Katarina, the floor is totally yours. Good afternoon, dear colleagues. So today I will introduce the results of the comprehensive analysis of cervical cancer screening in Cherkasy region. So we took this from the initial study that, together with our team, with the support of MOH and WHO Ukraine, that we've run at the beginning of the project. Okay, I'm not the lord of the clicker today. Someone has to be. Thank you so much. As you know, Cherkasy region, we split it in 4 districts. You can see those. So within this study, we've covered 10 HCFs. You can see this list on the screen, located in all 4 districts. So we've selected these HCFs with the help of health department in Cherkasy region using this principle. We have the primary healthcare centers, where women, starting from 18 years of age, she has a chance to get the serological tests and also other HCFs. which have these maternity and gynecological units with cytological labs. Only the maternity ward in Cherkasy, Center of Mother and Child in Cherkasy District Hospital. These had those. Apart from this, we also were surveying the Department of Health directly to understand what is the full situation, not just with the HCFs. Unfortunately, speaking about target audience at 100%, let's say target audience, target group of women, because since 2022, due to the martial law, we now have the sensitive data prohibited for publishing, like the number of population. Therefore, in this slide, you can see the number of women in the beginning of 2022 within districts, a district split in Cherkasy region. But we can only assume, using the registered declarations of women, they concluded with family doctors. In the bottom of slide for 2024, we can see that women aged 40 plus, they've registered almost twice more declarations, family doctors, compared to younger women. And this slide demonstrates the number of registered cervical cancer cases in Ukraine, a number of registered mortalities, okay, when it comes to cervical cancer as well. In particular, in Cherkasy region, we can see that the first detected case, 2022-2024, the share of women who had fourth stage from 8 to 12%. The first detection share of those who had third stage from 25 to 33 or even 34%. So what can it tell us? You know, that women, due to various reasons, maybe, well, they simply don't have some finances or other reasons, so they simply don't get those tests. Not many of them even are aware that they have to do it. At this stage, we can even assume tentatively that maybe the early detection program for cervical cancer, maybe it's not fully effective. So the appendix to this procedure on screening and early detection for cervical cancer and also monitoring of health condition for risk group patients, approved by the law 3068 that actually came into effect in the beginning of 2025. It was, so the routes for patients were identified from the PHC service provider office or the Obgyn. I'll briefly stop at that. If patient is 25 years old and this is her first screening, upon the condition she didn't have those screenings before, she's referred to PCR test. If symptoms are negative, if cervical cancer symptoms or pre-cancer lesions are identified, are detected, so she's referred to further examination or treatment for the oncologist. If these symptoms are not present, she is informed that when she has to take another test in future, every 10 years before she reaches 55 years of age. If she's 25 plus and she has HIV status or she lives with AIDS, well, she has gynecological examination, she undergoes that, and she goes to pap smear or the PCR test. In this case, these patients has to be screened every 5 years. And if the patient is from 21 to 30 with risk factors, the periodicity of screening is established by the doctor based on the symptoms. And she also is examined by a gynecologist and she's sent for the pap smear. If we speak about the screening here, that it starts with the PHC service provider office, well, it would be feasible to study according to the NHSU platform as of the study dates, February 2025. There may be some changes. It may be a little bit higher. In Cherkasy region, 67 PHC service providers were registered, 40 municipal, covering 226 sites with doctors. Unfortunately, we can't speak about the number of options providing treatment of the cervical cancer pathology because we don't have that information. According to the data of Health Department in Cherkasy region, there are more than 60 medical units where you can be screened for cervical cancer. So we can have these women's clinics, PHC units, and also polyclinics within the hospitals, oncological dispensary, and one private HCF where this you can get it free of charge under the contract with NHSU. You can see in the slide the number of cytological tests since 2022 to 2024 within the districts. Again, if we talk about statistics of cytological tests and examinations, it should be mentioned that in Cherkasy region, the processing of samples, so they use this coloring method. The coloring method, Papa Nicolau coloring method, it's also there, but it's used just as an additive, you know, just as a secondary measure. It's not about population screening and mass batches. What happens? We talked to Svetlana Tatarenko, the head of the cytological lab of Cherkasy regional oncological dispensary. She tells that Papa Nicolau coloring is a multi-stage process where half an hour you have to fix the sample, then 30-40 minutes for coloring. This whole thing is done manually, you know, so there is no specific equipment. It's not fully automatized, you know, and there are errors, of course. So you can only process up to 60 samples. Romanovsky's coloring method is faster, and they use other colorants, 2 minutes for fixation, up to 20 minutes more for the coloring. Maybe I may make mistakes with the timing, but this is the information I received. And up to 300 samples at once they can process. Statistics of pathologies within all the HCFs, I will not stop at these. You can actually check that statistics in Cherkasy Central Hospital, also in other HCFs, you know, it's much higher because they have cytological labs. Okay, therefore many HCFs refer samples to them for processing. So we talk about lab services now. We've touched upon that. In Cherkasy region, we have 10 HCFs with cytological labs in their structure. I tried to put them on the map. I don't know if I did that like properly, but yeah, there may be a small error. All these HCFs without the labs, they told us that they refer the samples for processing purely to state-owned HCFs via Nova Poshta or couriers who deliver these actually to the labs for processing. So usually it's done in Cherkasy Oncological Dispensary. And I also should mention the HPV testing. In state-owned HCFs, it's not done free of charge. In this case, they must notify that they refer the patient either to private lab or private unit like Synevo, Smart Lab, Lab Service. Unfortunately, only one of 4 of these labs, Synevo, has a contract with NHSU to make sure that this is done free of charge. 4014, a typical cell serology. This is the code of that test to make sure that there is an early detection of cervical cancer. When it comes to registration of patients and storage of results and screening results, HCFs mention various eHealth, MCMed, iHealth, and of course internal databases, and still paperwork is there. Yeah, paperwork still exists, paper registration. So I should mention that unfortunately there is no unified centralized system where it would be possible to track specific women, individual women, not referrals or tests. If a woman is referred from one HCF to another, she has like an additional examination, the route is lost. Okay, so that's why when we had this additional study done, so we understood that we can calculate the number of cytological examinations, we can count the number of actual referrals, but speaking of number of unique patients, how many of these from target audience got the screening, we cannot. Okay, Conclusions. Well, what can we say? The key response and the help that we provided. Trainings for medical experts. I will not stop at that, of course. Also, it's very important to raise awareness of population, because we've seen horrible rates and indicators where women had the 4th stages detected within the first screening. Women must be notified, of course, about that. Also, electronic systems, I mentioned those. What else? I guess that's it for me. For now, I can stop at that, and if you have any questions, please. Katarina, thank you so much. Very, very substantial study, a lot of important information. I think that you each can take something from this presentation. We will get some questions later. Let's move to the rest of presentation for us to get the whole spectrum, okay? I would love to have Ms. Halina Maestruk, Director of the Charity Fund, Women's Health and Family Planning. The floor is yours. So I think we will have a discussion. Just closer, yeah, that's very important. So we'll have a chance to discuss this, of course, and we are ready to share our experience within the study, because I really want to add something, but I'm, restraining myself. So I would like to speak about training. So you all do understand that Ukraine is a country where there are many medical higher educational establishments, like colleges, universities, and institutes. We understand that they have these curricula, okay? There are some programs, and our country is launching so many medical conferences every year. We have so many trainings elsewhere. We have associations of OBGYNs associations also. What I want to say, our experience, within a short period of time, when we covered 50% of primary level within the territory of one region specifically. And this is the experience that I would love to share. Not because we try to boast and show off that we're super unique or something else. No. We started with not even one meeting with people who introduced basically the region in different areas. And we were doing it at the basis of medical university. We had these talks. What is the problem? So quite often we lack these targeted interventions. Okay, what I mean by this, targeted interventions, and they work very well. So for example, when we don't disperse it, but when we take one specific issue, one specific aspect related to this target audience, and we know that these are the primary healthcare providers. But we also had OBGYNs also participating, but not very, very few when it comes to percentage. We know that these are people who live in that. It's their life and routine, and they work with that every day. And also the mid-level medics, medical personnel. And this is a colossal potential, to make sure that the screenings are taking place. One-day training, this is the format, because we had some limited time, we had limited budgets, you understand, and many other things. And within one region, where people can use local transport, be compensated the transport and catering. Of course, this is something that we really need during the trainings, because as they say, you can be super talented, but you cannot stay hungry for quite a long time. Okay, so we've designed a program, and we practically used the WHO recommendations and screening. We took WHO's recommendations and national documents. And I want to tell you that we have now some nice clinical standards. These are great, but Tatiana mentioned that these are still OBGYNs, okay? So when we tested it with the PhD doctors, we understood that these are very, very distant and far from further steps, especially clinical follow-up. So you need to have this OBGYN specialization for that and have deep knowledge of this area. So we designed a one-day program. as they say, with plain language, using plain language. Speaking about complicated things in plain language, simple language, with focus on their personal engagement in the story, let's say. They must be aware of what this disease is about, what is the concept, why it actually emerges, why we have these tests and screenings. Primary prevention, vaccination, because so many questions we had on vaccination, many different myths around it, you know? Screening, recommended algorithms, and I'll just stop at this now, because algorithms and there is like a paradigm, an idea in a brain that this should, like, since the beginning of your sexual life and up to the end of your life. It doesn't matter which infectious diseases you have, even if you're like with low mobility, someone has to take that smear, you know, and this is something that is, you know, engraved in the memory of people. So we explain what state is guaranteeing, which kind of quality, which intervals, because we now started talking about money. We now clearly realize that this is costly. It's not just about time. It's these are expenses, you know, it's pretty costly, the whole technological chain.
We also speak about sampling. I'll stop about that later, and about technical provision and sampling. So the most important thing, we also worked with the models of pelvis, and we brought them for each group. They were practice models, and they could see what these pelvis models looked like, because a lot of people, they never even held these gynecological mirrors in their hands. And as of today, I can tell you about our recommendations and vision. At least people understood that there is an element and component that even obstetricians and gynecologists aren't used to working with, because they mostly work with their hands by 80%, and here it's not like, you know, handwork, because they are not so used to working with that part of the body of the patient. So here you can see Antonina in her presentation. She paid a lot of attention to that. Now about communication. We worked on the invitation of the patient, especially the patient who didn't want to be in the appointment. So it was important to understand how to communicate with the patient who doesn't want to get the screening, how to convince the patient to get it. So here you can see a lot of different pictures, and I'd like to tell you that instead of the planned 3 trainings, we had 5 trainings. Offline trainings, which took place, and 149, no? Well, that's something wrong. We have way more people, 170 healthcare workers who successfully finished online trainings, and like all in all, more than 300 people in the region finished the trainings, mostly from the primary healthcare centers. But of course, offline trainings, probably it is effective. I hope it is effective. Probably she meant online training. So online training is very difficult to moderate, because you kind of work with the universe. The participants are quiet, they do not switch on their videos very often, but anyway, the format we have for online trainings is still successful. And here you can see the map. They started working with all the districts. Not even one district, not even one community is here which didn't send the representatives for the training. Mostly the training was provided to general practitioners or family doctors, and most of them never worked with cervical cancer screening. And basically before the training they knew nothing about that. And there were a few obstetricians, gynecologists who shifted into family doctors field, and they started working as family doctors, so they knew something. But what's more important, we started working with the nurses of obstetricians. So they participated in all the discussions and they polished off their practical skills and so on. So today we have a frank technical discussion, right? And I can tell you that these 300 people who were trained, what did we do to them? We informed them. They understood how important this topic is. And I get it. Well, for example, I am a family doctor. I have an appointment. Why would I leave all my stroke patients, heart attack patients to go and take smear test? Probably I'm not gonna do that. If the woman is here, I'm gonna leave everyone and go and take a smear test. I'm not gonna do that. Of course, people always ask a question. We have only 12 or 15-minute appointments. We won't manage to do that within this time. A lot of people say, well, if we have to do that, pay us more. And we cannot ignore that, because right away people say, we need to have a separate package from NHSU and separate funding. So this is the topic that is discussed with the primary healthcare specialists. So today, if in Cherkasy region, I'm sure that we will progress with this project, but we have to emphasize that each healthcare facility mostly has to emphasize on the trained nurses, regardless whether they have the knowledge in obstetrics or not. Because nurses, they are very flexible, they are trained, they are willing to do something with their hands. And in terms of communication, they are so close to the patients. If they learn the right messages and right skills, they will implement everything, and on that communication level it is absolutely effective. Of course, they share their doubts. For example, a lot of doctors who have such attitude, they say, I'm scared of this area, of this topic. I don't want to dive there. So a lot of doctors say, but you're not an obstetrician, you're not a gynecologist, why would you? So probably you have to do that if you provide specialized care. But mostly people say, people like in big cities, they can go to the obstetricians, gynecologists, specialized doctors. As an obstetrician gynecologist, I advocate for improving this field. Right now, our area of work will bring the results in the future. So if the screening will not just cover 12%, but 80 or at least 75%. Trust me, gynecologists, obstetricians will have a lot of things to do before the cancer pathology hits the woman. So, reviews and feedback. Not all the categories want to get that. For example, the woman of 55, according to MOH standards, will we refer the woman and say, oh, do not come back? And we explain in what conditions this poor woman with arthrosis and so on should not be put on the gynecological chair for the smear test. So what should we do with this 55-year-old woman? In what cases we have to run the screening and in what cases we shouldn't? The aim is to raise awareness of this topic, where people understand that it's not just the gastrointestinal tract screening. It's like two ways. You can take the pap smear test or other type of test, and we can get great results to prevent oncology. And of course, family doctors are obliged to do this screening. For family doctors, it was a discovery, because people not from the original center of Cherkasy, but remote areas who were not participating in different working group meetings, they were truly surprised that right now it's their responsibility on the legal level. And also it's important to communicate in an easy to understand way, and the format and the length of the training. Mostly people can sit through, and I can say that like some focal interventions are way more effective than, very long and boring communication. So our format of the technical discussion is also a one-day format. We do not stretch it for a few days, although we could. And not all the healthcare facilities are ready to participate in these trainings to participate in the screening because they don't have the necessary equipment and materials. Of course, Cherkasy will find a way out because we've had 5 months of pressure on us. We felt that pressure from all the sides to do that. Of course, it was positive pressure. And a lot of healthcare workers aren't ready to be a part of this process. And I do believe that their role on consultations and information dissemination is the most important one. Maybe they will not be taken the smear test at the gynecological chair, but their important advice, consultation that the person has to get that testing is important. And they understand that they have the function of referral to specialized facilities, and they are okay with that. They can convince the woman to go to gynecologists or obstetricians. That's great if this woman finally gets there. And the participants were offered to train mid-level health workers. I always say be creative with the recommended algorithms, guidelines, and so on, taken into account all the particularities. Also, there is lack of information about next treatment. And Cherkasy representatives wrote a letter to NHSU about the access to the information, because there is limited information, it gets lost, and people can give you the information only about how many patients were referred to other specialists, but what happened to these patients in the future is not clear. And we don't really discuss, but it's also a pet peeve. This number of tests is not the number of unique patients, it's the number of smear tests. Maybe one woman was getting 5 smear tests, but where is cancer? In the areas where there were no tests. But does this woman need 5 tests, or is 1 test is enough? Or maybe there are some women who didn't get even 1 test. And also people said that there is no information available. Next point, working group. Here, leadership, and someone has to get this will going, and there has to be leadership. I have experience of the Soviet Union, and I studied at Professor Bochman's lectures. I can say that there were leader oncologists who were bringing up this topic, raising this issue. We have inspiring people, leaders, and I clearly look at Tetiana, and I know for sure that she's truly an inspiring opinion leader on vaccination, on screening. We have great national leaders. Yet, I do believe in the work of such, interdisciplinary group of people working in the region, because here everyone has to be a part of this track. And if there is a gap in one place, you have to work harder in the other place. Without information exchange, without collective brain, I always say one bird flies, but the flock goes to Africa and spends winter in Africa, not where the other bird flies. Well, who knows what it means. And if people openly discuss that, it's an important point. I can tell you about the training program within the continuous professional development. We are ready to share this training with other regions so that you have your educational departments, your lecturers, and they can organize such trainings for primary healthcare centers, 1-day trainings, And I think that we are absolutely open for that. Mentor support at workplaces is important. And there is such an experience where people come somewhere, get people together in the field. And it's important to raise awareness in the field among the team members. Next work is related to prevention. Well, in a nutshell, we discussed something about negligence of disease. In Cherkasy region, 50%, almost 50% of patients were neglected. And the primary health care is so far away from oncological community. People don't get it that out of 50 women, 25 of them are with severe conditions. And next point, specific communication. Next point, information materials. Here we had big discussion. The only thing that we didn't work with, we didn't have a chance over these 5 months to communicate with the focal groups of the women themselves. We didn't hear from the women themselves about what is acceptable for them in terms of awareness raising. I understand that we set an ambitious goal to change their behavior, but at least we need to have an effective communication channel with women. And of course, behavioral change will follow. And of course, personal referrals, individual referrals. How can we do it in the way that the woman would have this personal appointment opportunity and referral? And also, healthcare workers feel the lack of communication skills. As if they get everything, they know the information, but when the person starts working, it is so difficult to discuss something that you never worked on. And also, we provided, I don't remember how many thousand, 10,000 for patients, 500. So we shared these forms. They are taken from the national documents, the method of pap smear test. Well, these leaflets are given into the healthcare facilities and people can read them and use these instructions and leaflets. And also there are referrals to the national documents and links to them. So you can read that information online. Thank you. That's it. Thank you. Thank you, Halina. We have online participants as well. Feel free to write questions in the chat. And we will also track everything you write and we will ask these questions. We have a dilemma. The presentation on information campaign that we slide into, should we take this presentation or answer questions from the participants here? What should we do? We have still a presentation from Valeria Didenko. So, no questions, then Valeria. Halina has already provided the introduction. You have no more than 10 minutes. So please do your best not to go over time. And then maybe somebody will ask questions. So we really want to go and have a coffee break before 12. Hello everyone. My name is Valeria. Right away I can tell you I don't have the medical degree, I'm not a medical worker, but I am the person who can help you. Go to and who can help you communicate with the potential patients or current patients of your health facilities and help them understand what they really need, that they do need to get the cervical cancer screening, and for all of us to work on this scheme and for you to understand what your facility has to do and what I should do as the communication expert. Well, to help you better understand that, let's discuss the barriers for women, like why they do not go to you and ask you about what is HPV, cervical cancer, is there vaccination, screening, and what to do about it. So there is a huge list of the barriers for a woman. It starts from personal fears, convictions, and religious beliefs. They believe in God and that everything is God's will. That is a very passive position, or what's meant to be is meant to be. This is very, very popular opinion in the remote areas. In my family, I have a lot of women who say, no. It'll somehow disappear the way that it appeared. And the person may be just scared of doctors, scared of testing, and scared of the need to get the treatment in case the test result is positive. So you as doctors have to keep in mind all the barriers. when you communicate with the patients, use facts, arguments, evidence that may convince the woman to make the right decision. And here, I'm trying to be as brief as I can. If you have any questions, feel free to ask me later, but right now the priority is to be fast. How can we convince a woman? Let's change the word convince to motivate. You know, you can't convince a woman. We think that it's the right thing to do, but we shouldn't be very persistent and authoritative in communication with women. We have to be the friends and assistants for women to make the right decision, something that'll help the woman's health. Here we can rely on international experience, and I found a great fresh research which was published a few months ago about what really helps female patients to make the decision to take the screening, and how the healthcare facility can use the information campaigns and how that changes female positions.
What should we know here? That quite often women don't understand even what are these HPV, whatever, acronyms. They may know how it's deciphered, but they don't know where it gets in their body from. That's like why it's important to track the progress of infection, of disease, and to prevent the pathology distribution. So they may not even understand like which diagnostics method are there, but what is really important and interesting, in Ukraine, everybody knows that Pap test exists. Nobody knows what that is. So even when I was preparing, when we started preparing to this project, its implementation, even in our own team, I'll just I felt very ashamed back then, but I always was actually getting this Pap test. I realized that I can do it like annually when I come to gynecology, but I didn't understand what it was. I had to Google it, the details. This was a great moment, that made us a little bit more sober than we were before, because we understood that this is the entry point. If I am in the public health area and my knowledge level is so low, what can we say about a woman who never even was interested in that, who never Googled that? Okay, what already I mentioned earlier, do not force, do not convince, but actually motivate a woman and invite her to screening, like truly invite, and respect her choice first and foremost. Also, for a woman it would be better, for a patient it would be better if you, let's say, use the proper terminology, give adequate names to things and concepts, take needs of various audiences into account. That's what we do every day. Because it's obvious that you will not tell a woman who is 70, let's say, you will not speak about pregnancy risks or something. Of course, it's obvious. You have to adapt it to your patient fully. Okay, the need for tools and equipment to make an evidence-based informed decision, additional materials like leaflets to distribute, or the hotline number, to give to a woman, where a woman can get some help or maybe additional explanation. This is the example of what is used abroad, and we'll step into Ukrainian reality, but I just want to show you. The call for action, the statements, the wordings. Help us to help you. Screening saves lives. These messages. Screening can stop cancer before it even emerges. So we give positive statements. We sow positive seeds. You can do the same thing when you're consulting, and it actually works. Stepping in the positive mood. When we talk about you and your specific HCF, like what can you do with within your own capacity, even without engaging donors' money, without actually getting some orders from MOH, without local funds or additional orders from the top? You as an HCF, what can you do autonomously on your own? It would be possible for you, let's say, to send personal invitations for screening, give a call, to a patient, those who fall under the risk group, for them to undergo the screening, cervical cancer screening. Organize some, cooperate with media. Like annual, I know that journalists, they have in their schedules like some dates, specific dates. They can relate to certain topics. When they have these dates, they take interviews. They go to HCFs and they take interviews there and talk to doctors like about prevention and so on. You can actually do it on your own. If there is some extra money, well, the list expands. Expands with what? Advertising? I don't know, banners, whatever. Okay, what we did within these 5 months. So we managed to do 3 things. What Ms. Halina mentioned, we had no chance to talk to women themselves, of course, to understand what they would love to get in Ukraine, in full-scale war reality, let's say, in limited funding, limited logistics reality. But the universal barriers, reasons that women may face in the screening access, like personal fear or lack of understanding, lack of awareness. If women don't understand what HPV is or cervical cancer, this is something that is common for women in all countries, but we just use the Ukrainian experience here. What we were telling about here, what we managed to do, so we prepared some nice materials explainer, we call it, where step by step, stage by stage, we provided in very plain language the explanation of what is the problem with cervical cancer, where to go, where to call, who to talk to. We also prepared a series of posts, and we were distributing these in the Cherkasy region. In communities and chats, in accounts, it will even disperse more within some time. PHC supported us. This week we will have some active wave. We're about to have it. So we ensure the outreach in social media. The outreach, we're not like, we engage women via social media, let's say. We're taking them out of the general population and catching them. An alternative for personal invitation is screening. What is there? So the most important thing is that there is a space for HCF contact data. It's not a full replacement. It's not fully effective replacement of a call or email, of course, or notification to a specific woman with specific referral, like with a name, like, "Dear Miss Maria, please, we'd like you to visit us, la la la." But this leaflet gives some basic information, some ABCs, and it's quite catchy, and women already knows, like, okay, the pain, that you're telling about, the managerial decisions. Yes, Antonina. Wonderful. So you took this huge pile of work, the role, you managed to organize everyone. It's not a question of feasibility. Yes, we're doing that, we're performing that. How to make sure that we implement the order for the decision to be effective. There's a leader. In the process, we have a leader, like the head of the health department in Cherkasy region, okay? The manager. Yes, this whole thing, like any implementation, is based on, it's about personality, it's about people who are implementing. Cherkasy region is a lucky one, but I do hope that Kyiv region, as of now, you have a powerful leader. Well, maybe Miss Natalia, she will prioritize certain steps for future, and she will, of course, prioritize this important thing as well. But Valeria, she's with us. She is representing the MOH, and she leads the primary healthcare sector. For her, the screening coverage, results, and effectiveness, yes, is important. Maybe she will organize a working meeting specifically for managers, healthcare managers, and Antonina will share the experience, and some managerial tips, on how to impact. So we need your grassroots initiative, and we're about to strengthen that initiative. Our aspirations to make sure we get the results. Tatiana, dear colleagues, I just want to introduce my admiration with your results. When I checked the agenda, I spent a whole day, I'm spending this whole day now to listen to all of you, because I understand how important that is, this discussion. And the issues that we discuss, we can design anything at the top, we can have a side eye, but when you go deep into that, when we work with those who are the beneficiaries of those regulations, a lot of unexpected insights we may get on the pros. And I was listening to them, so grateful. Halina, thank you. Tatiana, thank you as well. Antonina, brilliant. That was amazing. Okay, speaking about the problem that we heard from the doctor. Yes, this is quite a painful issue. It's like we were talking about the bacterial vaginosis issue, okay, like yesterday. Okay, we understand. In the same area, bacterial vaginosis is a risk factor for persistence of HPV. And we have this standardized document which actually gives clear criteria for diagnostics of back vaginosis. There is no single state-owned lab, municipal lab, that is able. We don't have any single spot where we can have the AMSIL criteria. You know, in the state, basically, there's no pharmacy bringing the necessary pharmaceuticals there. So we have the WHO standard. We put the standard in the document of 2022, but we're not implementing it. We're not enforcing it. And I raised that yesterday. And also the lab service issue is coming to the surface. We don't have any regulations on lab service at all. So these templates, analysis templates that are approved for our state-owned labs of my age, let's say, during the Soviet Union time, these were approved with no bacterial smear, with Nugent AMSIL criteria, nothing there, high ISIN criteria, nothing. And therefore, the doctor, colleagues are nodding. This is a huge problem. At the level of MOS, when the level of MOH will have an order that will tell us how the lab service, what kind of tests that should carry out, which analysis, which templates they should use, you know, like then we will use the same language, we'll speak the same language. And now we have some titanic efforts, we're doing that. Each PHC manager, each health department manager will just try to break this wall, you know, with bare hands. So I didn't expect that this will come to the surface, but after I heard it from the doctor, well, we have people here who really are caring. Please pay attention to it. If we push this forward, a lot of practitioners, a lot of women in particular will be grateful. Second question I'd like to raise. Okay. So in the process of designing the regulations, when I talked to Tatiana, I learned a lot when it comes to organization. On one hand, we have a PHC doctor. One has a database. So PHC level today has all the database of women, let's say. This is a wow thing. It's a great. Second thing that I learned, second insight, that when you start handling the organizations, you have to learn to count money. And as a clinicians, how do we see the situation? How do we observe that? Yes, for each woman, we need to do it the best way possible. But as organizers, as managers, we count the money. If we have cytological tests, okay, if we have the Romanovsky Gimza coloring, we are committing a crime then, financial crime, when it comes to the state, because we intentionally spend our money on the test which is not informative. So we actually confuse the doctor, we lie to a doctor, we lie to a patient, you know, and we just waste the state money. Who should be motivated? Who should we talk to? Okay, colleagues, we're a country that lives a war. We have to count every single grivna. Not every year. We don't need to have an annual cytological test. In both regulations you showed once in 3 years. If a woman, if she has a normal cytology, okay? If we take the cytological screening path. But if we talk about cytological screening, Halina, you know, showed us a lot of problems. Chairs should be procured, you know, speculums, and teach doctors how to take these smears, basically, practically. It should be taken properly. Romanovsky Ginza coloring, yes, but you have to take the smear in such a way for this equipment for the smear to be taken in a transformation zone. Nobody understands what is transformation zone. So if these cells of the transformation zones are not taken out, again, we wasted the money, okay? And this pseudo result, quasi result. So that's why the primary HPV screening is what the world takes. This is the path. What I really want. So for us, raising the PHC, primary HPV screening, it should be pushed as well. At least 35 years to be mentioned in the documents. NHS is not covering the HPV today. NHS covering colposcopy, and doctors carry that out. Why? Like, nobody understands why. Biopsy. Okay. Why? From which zone? Okay. Nobody understands. Miss Antonina, sorry. You raised an issue that we don't have a feedback, we don't have results. Okay, we have the cytology, we don't know what to do with the cytology results. So I would love, well, I know that there are motivated people, Tatiana, Halina, if maybe it would be possible to think how to upgrade this informational system with some appendices, I don't know, using some technology to create maybe some digital tools to track, not to have the same smear for 3 times, not to carry out the colposcopy where we don't need it. Then the money, we'll use money wisely. And with the primary HPV screening, we'll do it much better. Okay, maybe at the level of region it's possible. Antonina, if it's possible to launch it as a regional pilot, this can give more answers to questions. Thank you. Whew. Yeah, so it's about time to have some coffees. Yeah, Tatiana, speaking on important decisions, okay? I don't want to take the bread out of the mouth of NHS because they take care of collection, analysis, storage of huge piles of medical records, okay, and information that is accumulated since 2018. But I just want to give you one insight. I have access to this information and I actually can share.
Well, then again, I believe that we have the closed technical meeting discussion, but the head of our state made the decision to change the format of our government. We know well about the change of the cabinet of ministers and the prioritization of some tasks. I'm not saying that we have new tasks, but anyway, there are a lot of key tracks that our society is waiting for, and they will start soon. And what you will say is the answer to the key task that we will soon see. That is the office of the patient or cabinet of the patient, probably office of the patient. A lot of the digital solutions in our state are implemented thanks to the leaders, and these solutions are so ahead of the EU digital solutions. So I think that such consolidated suggestions are quite timely, because it's time for changes which are needed. When we implement this solution, the office of the patient, all the technical areas related to the storage and processing of data, the effective use of data, all of that will be a part of that office of the patient. So I think it'll take a bit more time to be able to see that and be able to use that, but for sure this is the priority of the government. Thank you, colleagues. We have just one question here. Hello, Arkady Vodyanik, the head of the Medical Services Department of the WHO office in Ukraine, and right now we're running the analysis on referrals which are provided by family doctors and what is the percentage of them which was closed, and a few questions. So in 2023, family doctors had 10,000 referrals for pap smear test, and the closed number is 10%, only 1,000 of the cases. In 2024, 26,000 referrals, so more than 150% more, and 1,000 referrals were closed. So it's only 4% of all the referrals which were closed. If we speak about the referral to PCR test of HPV in 2023, it was 220 referrals, none of them was closed, and in 2024 it was 2,800 referrals, more than 1,000, 40% of them were closed. So my question is the following. We can see the rapid trend about the increase of referrals. In 2025, this trend will increase even more probably, but I want to hear the colleagues' opinion regarding the engagement of family doctors to close this referral so that female patients would get the tests that she's referred to get. And we heard that we cannot see that in the e-health, in the digital records, but the family doctor can contact the woman and with raising awareness of the need of screening, maybe we should also raise awareness for the woman to actually get the screening and be referred to the specialist for that. When I spoke about the order, the decree, I said that back then, together with the team, we worked on the formulation of this decree related to the patient pathway. The final result of this test is one of the mandatory elements, points, which are stipulated by that decree. But related to the family doctor, the motivation to get the test and this feedback, first of all, I can tell you that I truly love primary healthcare level because I do believe that they are intellectuals among the medical workers. But being able to multitask for any doctor related to the patient, and sometimes if the doctor is multitasking, it helps not to waste resources if there aren't simple tools to track the result after the test. This is a challenge we can say about it, but if people don't have the easy-to-use tools, we can't require from them to sit there and calculate manually and track this information that could be automatically generated so that the doctor would have access to this information from the work desk, and so that the doctor would have some motivational incentives inside the facility. If the screening programs run successfully, there have to be some incentives for the doctors. But the woman needs to be informed that the referral is not something that you can stop on. You have to finish that process and get the specialized service. So any communication channel, any assessment of the readiness and preparedness to communication messages, the trust to the healthcare worker from the population and from women is huge. Of course, depending on how this dialogue is built between the woman and the patient, taking into account the basic trust level between the patients and the doctors, all this trust level will impact the results. So you said 2023 and 2024, they are not indicative related to the assessment because on the legislative level it wasn't regulated, and the number of referrals which were issued shows that the family doctors understand the necessity of such testing. We get that. If some areas are regulated, they are fulfilled. So when the primary healthcare doctor refers the woman for pap smear test, it shows how good this relationship was built between the doctor and the patient. We have a lot of work ahead of us, and this feedback will be the next planned activity for the plan of the implementation of oncological strategy for 2026-2027. Thank you. You know, we've discussed effectively, but we already finished our coffee break. But comments were important. So here is what we offer. Maximum 15 minutes for a coffee break because we have a very intensive program and we cannot, first of all, take your time and make this event longer. So please be back in 15 minutes for the next session. Thank you.
1, 1, 2, 3. Точно, що заберу. Що їх посвистю трошки? Один, два, три. Один, два, три. Один, два, три, 4, 5, 6, 7. Що? Я убрав. Оу. Іде? Іде чи ні?
Раз, два. Та й працює.
Okay, we're checking the sound right now. Okay, dear colleagues, just we will we'll postpone the lunch, not for quite a long time, but anyway. We have our third session, implementing systems of screening and early detection of cervical cancer in other regions. So I would love to give some information out to raise the awareness that for the very first time I'm reporting for a 5-month project. I've never done that, usually long-term projects, and I'm so surprised like how much we managed to do. But it's quite a fantastic thing, the story, like the lab component is quite an amazing thing. Maybe it wasn't even planned, that substantially from the very beginning, but for me, it's such an honor, great honor to pass the floor to WHO Bureau in Ukraine, and Laura Cherneshova will take the floor. So Laura was actually an expert who started studying and analyzing this issue, and I think that her message will be super important. Yes, the sound is fine. Thank you so much. Thank you. So, dear colleagues, thank you so much for this opportunity to deliver my speech.
Ви попереключаєте чи дасте новий екран? В ручному режимі буде екран.
Добре. Мене
Okay, so my name is Laura Cherneshova, WHO Bureau in Ukraine. So, can we have the next slide, please? So, in National Cancer Registry of Ukraine, annually, more than 3,000 cases of cervical cancerous cases registered. And among these first detected ones, more than 10% of women have fourth stage of cervical cancer. So every 10th woman basically comes to screening with late cancer, with grave cancer. So please, can we have the previous slide? So in national legislation, what we have, it stipulates the screening with cytological methods, so Papa Nicolau coloring, or the liquid-based cytology or PCR test. So selection of any method, this is the responsibility of the region. They select depending on technical capacity, financial capacity, depending on the level of qualification of the lab personnel. But in Cherkasy region, for example, where we had also lab personnel training launched, so what we identified there, what we saw there is that among the cytological tests, what is the dominant? Romanovsky Himza coloring is the dominant one, but not the pap test, not the pap smear. Also, what I'd like to mention, what we observe, the variability in the periodicity for screenings. Among the surveyed ones, many recommended to have the screening annually, but some defined 3 or 5 year period. Also, what we observed, the lack of lab personnel awareness, like regarding the issue when to start. So the HPV screening is recommended to be launched at 30 or 35. But often, we also frequently heard that they recommend the earlier age. It actually shows that there is a low awareness of lab personnel and doctors on implementation and use of those methods. Also, PCR. Also, the PCR test, HPV PCR test in state labs was not carried out. Patients were referred to private labs, but in state-owned labs, this test was not carried out. Please, the next slide. Yes, HPV PCR screening, it's not performed in state-owned labs, yes. This is an answer to your question. We don't hear the question, unfortunately, but yes, that's what I will tell about, yeah. I would like to demonstrate some materials to you. Yeah. So if we actually compare Romanovsky Hemza coloring and pap smear, Romanovsky coloring is absolutely unacceptable for cervical cancer screenings. This method has very low sensitivity, 30-45%. Okay, thank you so much. And so one previous slide, yes, this one, thank you so much. So this method, Romanovsky-Hemza coloring, has very low specificity, from 85%. Standardization of this method is highly variable when it comes to labs. It's very different from lab to lab. Patient can get completely different result, the same patient, with her smear in different labs, you know? And different experts may give different results. So this method can be integrated in limited way in the scheme of interpreting the results. And despite of the low cost, this method is super popular for screenings, you know, but we have to use more informative, more complicated, of course, technically, and more expensive one, pap smear. Yeah, please, next slide. Thank you for patience. Patience is the largest virtue. Next slide, and one more forward. Thank you. This one. This is the one. Okay, but even pap smear is not 100% like fully informative, let's say, under the cervical cancer screening. If we compare it with PCR test for HPV has high sensitivity, quite high sensitivity for us to detect the CIN1, CIN2, and CIN3. I mean, of course, PCR test has its disadvantages. Quite low specificity, especially for young women. HPV is detected in the body of a young woman when she starts having sexual intercourse. It's normal for the virus biology. But because the PCR test has very high sensitivity, more than 90%, it actually gives a chance to have the following screenings using PCR tests not more frequently than once per 5 years. So this is economically more efficient and effective when it comes to PCR test under the screenings. Despite that the PCR test is more expensive than serological test, still, at the expense of smaller frequency, it's still more feasible. It has higher sensitivity, as I said. It's standardized when it comes to the labs. It's much easier to automatize and to scale up the tests compared to technically complicated pap smear. Please, the next slide. Therefore, international recommendations actually tell us as one of the options, they give us one of the options for screening programs to combine PCR tests and serological tests. That is how we minimize the disadvantages of both methods, and that's how we increase effectiveness of HPV screening and serological screening, and also we increase the intervals between tests. In some countries, they even allow to have this screening 1 per 10 years. And that's how we decrease up to 2 patients per 100,000 of studies, the morbidity, and that's how we will have the lower mortality rate eventually. So that is how international recommendations, they tell us PCR test is recommended as the key screening tool. It's a key screening method at the first stage of screening. Also, PCR test can be used for monitoring of therapy, to manage women with ASCAS, just to clarify the colposcopy results or serological test results, etc. So, coming to the lab component per se, what is the role of labs, in cervical cancer screening introduction? So this is the old presentation, yeah? Okay, we're about to replace it with a new one. So the role of the lab component. Yeah, this is not my day-to-day. It happens. The role of lab component in screening implementation, effective screening implementation, the cervical cancer screening. First of all, it's about introducing molecular methods, including PCR, in screening programs. For example, in Cherkasy region, we have 6 facilities where we have fully equipped functioning PCR labs and well-trained, properly trained personnel. Thank you so much. So among these HCFs, we have Cherkasy Regional Center for Disease Prevention and Control. They have 3 PCR labs. Center of AIDS prevention and tackling, they were actually interested in introducing the cervical cancer screening at Uman Hospital. They have the trained personnel. They're interested. Also the regional hospital, oncological dispensaries there, and also the infectious hospital. Speaking of serological tests, as in Cherkasy region, we have at least 10 serological labs which do not carry out pap smears as it's too expensive and it's really technically complicated procedure. Pap smear can be taken in Cherkasy region only in oncological dispensary and not under the screening, but within the further diagnostics. But screening, colleagues, screening has to detect pre-cancer transformations, not the cancer itself. And oncological dispensary is explaining why they are not introducing pap smears in their routine screening programs because this is technically difficult, you know? This is manual, fully manual method, and they simply don't have time for proper coloring, you know? Therefore, one of the options to introduce pap smears, you know, to scale it up under the screening programs, what can we use? Automatization of labs, you know, automatization of the coloring procedure, you know, the glass coloring procedure for us, for them to be able to carry out these pap tests, more of these actually. Apart from that, labs must stick to the principles, rules, and standards of biosafety and quality management, and we have to train our personnel all the time. Within the project, in May-June, WHO Bureau in Ukraine held a couple of events, 3 webinars for all Ukraine with large coverage. We had more than 500 participants there. These webinars were dedicated to such topics as PCR in cervical cancer screening, and also these were dedicated to quality control for PCR tests to detect HPV for those labs which already introduced HPV testing, and they select between the tests, you know, how to control its quality, whatever. Apart from that, we also had 2 5-day practical trainings held. In general, each training lasted for 40 hours. These were 5 full working days, basically. So we launched these trainings in Cherkasy Regional CDC and also in Uman Central Municipal Hospital. We engaged to these trainings apart from local lab personnel, heads of labs, doctors, lab doctors, other personnel, and also representatives from the regional AIDS prevention and combating center. Within these 40 hours, what we managed to do, what we accomplished, we had practical and theoretical sessions delivered on biosafety, on best lab practices, on prevention and elimination of contamination, for example, and also the PCR in diagnostics, specifically HPV diagnostics, from the very beginning to the end, you know, from the collection of biomaterial and up to results delivery. So preparing the samples, extraction, amplification, you know, qualitative PCR and so on. Quantitative, sorry, PCR. That is how we managed to increase the professional competence of the lab personnel. And I think that personnel of these labs, well, these people are fully ready to introduce the this test under the cervical cancer screening. Thank you so much, and I'm actually ready to answer your questions. Yeah, we will have a Q&A session, of course. I would like to introduce, you all know very well, we have the next speaker, our MP, representative of the Parliament, Valery Zub, our colleague. He's an oncologist, and everything that we've had within these last years, the concept for combating cancer, like this is basically the locomotive that's pushing that forward. But even from the standpoint of screening, Chernihiv region has become the first one that managed to introduce that systemic screening, HPV systemic screening, well-organized screening. So good afternoon. Thank you so much. Greetings, ladies and gentlemen, and I joined you a little bit later. I'm sorry for being late. So I joined you a little bit later. First of all, again, we have our professional holiday. with the minister, with the Speaker of Verkhovna Rada, we're actually awarding the best one. I would like to give these awards to all the medics, to all the doctors and all the medical personnel. We live in such a turbulent time that each of you is doing the impossible things every day, and this is something that just I join all these warm words today, and this is something that should be specifically mentioned. I'll tell you about the project, what we're planning to do now, and what we're planning to have in Chernihiv. I do hope that we will actually implement that, because we have really serious support from our health department and the administration. So we plan to implement the cervical cancer screening project, but I'd like to start with a larger scale.
In general, I want to thank you that you always initiate all of these ideas, and I kindly ask you for all our meetings, sessions, working group meetings. At the end of the day, we have to document our work so that it would help me as member of the parliament to implement this project. You see, let me start from the general points. As of today, we've started. We already have the immunization schedule, and from January the 1st, 2026, we will start HPV vaccination for girls, but it's just the first step. The next step, first of all, we will expand the age group of girls, and the next step will be the vaccination for boys. Then the next steps will be reimbursement of the cost of all the laboratory and other methods via NHSU. I think the NHSU representative is here with us. So it's also really important, by the way, in this event. We discussed this with Natalia, and I do hope that we will make it possible. So, a lot depends on your activity, engagement, proposals, and such meetings. All our next steps will depend on that. We definitely are not going to stop on that, because it's just the beginning. First of all, this resolution that we will have, or maybe some joint project as a result of this meeting, all of this has to be sent to the committee, to the minister. By the way, we discussed that with the minister. So we have to create the general concept that it is created here in this room, so that later we'd be able to expand all our possibilities. I can tell you the following. Probably you know about it, you heard about it, that the checkup is being implemented, and probably NHSU will say more about it, related to stroke, heart attacks, non-oncological diseases. But at the same time, we want to have the oncological checkup in that program. And here and now we have the discussion of all the projects. We are working on the 2026 budget, and we need to understand right now what will happen in 2027. So we can tell you that what we have in 2027 will actually depend on what we do this month. Unfortunately, I will have to leave you shortly to go to the meeting with the committee of the ministers. I asked them to let me come here because that's an important meeting. So right away, I'll inform you about that. Now a little bit about Chernihivska region, Chernihiv region. You know that it's on the border with Belarus, with Russia. It's not a very simple region, oblast, and it's the big region. There are a lot of different municipalities. The density of population is very, very small, so the healthcare topic is always a complex one, probably the most complex among all the regions, which are the pre-frontline regions. So these questions are always being discussed, both in the administration, in the council, in the directorate. So what we've highlighted as a separate track, the screening track, once again, it says that the government paid attention to the problems of people who are in such remote areas and who come to doctors the least. I know that for sure you've discussed that. You know that the problem of cervical cancer is a serious problem in Ukraine in contrast to all the other developed countries, especially the countries where they have HPV vaccination. We have absolutely incomparable numbers. That's why here you can see the general problem that everyone knows about. So here in this room, I will not need to prove how important it is to conduct early diagnostics and cervical cancer screening and HPV testing. That's an important thing to do that needs to be done, and thank God we've planned to implement that already. Let me repeat and say, probably you've heard that many times, but this is our true achievement, because this year, for the first time in the history of Ukraine, the money was allocated to procure the HPV vaccine on the centralized level. We already know what vaccine it'll be, and thank God we are getting down to work, and we are a part of the hundreds of countries that provide HPV vaccination at the state budget's expense. And this is the state program already, I mean HPV vaccination. Now, please pay attention to this slide. It's a tiny bit different from all the orders that we have of 2024. Thank you, Tatiana. I want to thank both Tatianas. These orders, decrees were successfully adopted, and the doctors use them already in their work, so please pay attention to this. Look at number 2. This is our preference or wish of Chernihiv region, so we considered running the HPV cytological research in a bit different category of people, and we narrowed the diagnostics timelines a little bit, and we exceeded a little bit the boundaries of these decrees and orders. We simply took the best global experience, and we tried to prove that on the level of the region to make it happen. I don't want to say that it's something unique, but you always have to aim for the stars to truly implement the project, and I do hope that we'll make it work. That's why these numbers may differ a little bit, and you will see the beginning of cytological testing and HPV testing. Like, this information differs a bit from MOH orders. Next. I also checked some discrepancies among the orders, and taking advantage of this opportunity, we probably need to discuss this and probably regulate that to be on the same level. And one order that's related to screening and the next order that's related to screening, well, we have to speak about it as specialists. Now about incidents, cervical cancer incidents. Since I work in the oncological center once a week on Saturday, but I have to represent the work of the oncological center because our representative couldn't come today, that's why I have to show you our statistics and figures. A year in Chernihiv region, about 80-90 women get the diagnosis of cervical cancer. As a rule, look at the severity of this case. In most cases, this is the severe cervical cancer. Now a bit more about our region. Probably no one will remember this information, but let me say that our region is divided into 5 districts. 2 of them are absolutely pre-front line region districts, Novgorod, Syrivsky and Perukivsky, and these are the pre-front line districts where part of the villages are evacuated and the access to healthcare services is limited. Moving on to our project itself. In all our meetings, when we gathered the specialists, we spoke about the role of the family doctor, of the GP. So there are a lot of speeches about it and reports about it. For sure, we need to encourage, incentivize family doctors, give them some information, clarification of what their role is about and what their responsibilities are about. Of course, 90% of all the people, of all our residents, go to the family doctor, and family doctors have to know about this problem first, and they have to know how to conduct all the diagnostic tests, where to send the materials, test materials, and where to refer the patient if there is suspicion on some condition, and they need to understand the organization of the cervical cancer screening. The number of population that needs screening is about 240,000 people of the age group 21 to 65. This is the population number, and even by districts, we have the understanding how many people need and what district, how many people need these tests in what district. So, if we take and here you can see the screening concept itself. First of all, we've been through the first stage. We've analyzed the situation. We know the number of women who need the test. We know the number of doctors we have. We know the number of laboratories we have. By the way, previous speaker said about the number of laboratories in the state facilities, and we have quite a lot of them, almost in every district. With this Center of Disease Control and Prevention, we've actively cooperated with the CDCP, and luckily they initiated all these changes themselves. So we didn't come to them, they came to us saying that we have so many laboratories, we don't even know what to do with them. Either we have to give them to someone, close them, or do something with these laboratories. So they initiated this project, which is about using these laboratories and finding the possibilities to implement all the screening tests. So we conducted the monitoring evaluation. Next step, we need to understand what we will do with the test materials and tests. So if we can build the sampling, cytological swabs, or HPV tests, if we can organize this mechanism, what to do about it. The most difficult issue in our region is the delivery of the test materials. The first thing which was suggested is the system of self-sampling. And the second thing we plan, the main method of diagnostics will be HPV testing. We will try to step back from cytological research, even Papa Nicola, because that's even more difficult to implement in our region. And the next thing is transportation. I said about it last time, and let me repeat that again. We had a meeting with the Ukrainian Post Service Ukrposhta, and we discussed this project with them, and maybe they are already ready and prepared. I haven't clarified before this meeting. They are ready to prepare special boxes to transport the test material. So as of today, the pathway is the following: self-sampling and family doctor, and then Ukrposhta and the delivery of the test materials to the laboratory. So then the laboratory informs both the doctor and the patient about the test results. There is one situation. As of today, CDCPs and so on, they are not in the ISO system, and they don't have the access to that. That's what we're working on, trying to fix that, and I hope that we'll manage to do that. That's it. Thank you. As I see it, you will not stay here with us till the end of the panel discussion. If there are any questions or comments, feel free to ask Valerie. Or maybe we can listen to Orest, and then there will be a Q&A session, and I will leave after that. So it's a great honor to give the floor to Orest Trill. He used to be a big coordinator of multi-year World Bank project in Lviv region, the only one in Ukraine, oncological prevention. Usually we have institutional sclerosis. People change, people come and go. Thank God Orest is still here with us. And from the moment when the project finished, it's been 10 years, and we expressed our wish to look at what worked well and what didn't work that well. So good to see everyone here. Actually, it's been 10 years after the end of the project, and I'll try to show the second wind of all the results. Two curves here. The invasive cancer and below cancer registry, and below in the region we had more narrow curve. Maybe it's due to the fact that in our oncological center we had a specialized unit of cervical cancer, and they were fighting for that unit and advocating for that and working a lot with the general network on screening and concentration of all the data of the patients. Even, for example, early cancer stages are identified in the general network, and the specialized centers may not get that information. So maybe we somehow had this work more balanced, but it wasn't still satisfactory. In the UK, for example, in the screening, the 0 stages exceed the invasive ones. So we were motivated to have 2 types of screening for the mammal gland and cervix. For sure, for mammal gland, mammographics is revolutionary, and everything got better. And in the cervical cancer incidence, it started going down after the population screening. We can actually combat cancer before the onset. But this curve is highly important. The moment the results, the cancer results will go down if the coverage is good enough. So coverage is quite an important point. I was in one more meeting, I'll show you a picture of it later, where the post-Soviet countries were analyzed, and they said, well, we do the screening of cervical cancer, but as it turns out, it was opportunistic screening, and it was just a waste of resources, and everyone was shocked about that statement. It's not a trendy thing to show, but I couldn't help showing that. Back then, our chief doctor reported, I just wanted to show you the year. Everything started back in 1969, and there were quite a lot of researches conducted. As of today, it's 2.5 million people. Let's divide into half. So I have a feeling that they screened all the women. So the number of screenings didn't equal with the number of women. There were fewer women. But anyway, it shows that the screening interest is wavy. There are ups and downs. But our results before the project, because the project, I can tell you, was 10 years ago. And what is it that we saw? That invasive cancer incidence was going up, and in situ cancer for some reason was going down due to different contributing factors which concerned us. We wanted to have the opposite situation. We wanted to have 0 stage cases, and we assessed the population. Right now we don't have the access to, maybe somebody has, but we don't have the access to, on each region, we don't really understand our demographic situation, where the women are and who needs to get the screening. Back then we had this information, we had the demographic curve, and we understood where there is a lot of women who need the cervical cancer screening, and Also, mammary gland screening is important here, but mammographers are quite expensive. So we understood that something could be done, but we also needed to analyze and make the right conclusion. And without the resources, it was difficult to do that. It was impossible to analyze the journals. That's why we thought about the digital registry of targeted female population. That's an important point because we have really different technologies. NHSU provides a lot of different data, and we started thinking about the digital registry, which would have the medical information system. And before, like back then, e-health was something out of space. We didn't.
So we decided to personalize the database women, the database with access given to each branch. Family doctor, meaning primary, then gynecologist, specialized oncologist, lab personnel, and also the feedback. So to make sure that we analyze the actual scope of cytological tests and women that are covered. This is our delegation. We thought we were heroes, super smart, and this is an important benchmark. This is an important organization, International Organization on Cancer Studies. And we were led by the head of department. For a week, we were diving deep into this environment. They prepared a training for us, like something like today's event. Like which resources in Ukraine, the population. They were asking simple questions. And when we tried to answer, we started realizing, wow, we're stepping into something serious. And we had to move forward. But this is just a lifetime experience for us. And I advise specialized oncologists or people who want to handle screenings, please read, or better to talk to. These are very open people. You can talk to them and get some consultations, and you'll have access to important sources. So we had the bidding procedure, the procurement, and the information resource. Dr. Alex Lviv company was chosen for that. Maybe this is an advantage. Like every week we lived basically in their offices. When an IT guy sits there and he's like he's understanding everything, but when a doctor is sitting next to him, the doctor can clarify some stuff. And then we had some internal dialogue between the teams, and we managed to achieve something. It was really a hard process. Maybe now it's easier, the certificate, the safety compliance certificate, it's awarded level of SSU. So there was a chance for the gynecologist to enter the examination with full protocol. This is very convenient for the gynecologist to use that. This was actually very attractive for doctors. Colposcopy to be entered, collection of smears and samples. So you take the smear, the doctor, there's one protocol, and cytologist to read, let's say, the smear results, not to just expand the number of those. We've integrated the existing classification and Bethesda classification, but what was really important for us to analyze, a chance to analyze. We had personalized information, and in the lists, we can analyze it region by region, something that we really lack. So we have some activities at the level of department, municipality, or region. We can't analyze the results, the number of covered, the number of cases identified within the smears. So the integrated information resource gives this chance. Who's the monopolist today and serious player? NHS. Well, but they have other tasks, many of them. And of course, they will not create a special resource for us. But the personal patient's office, well, doctors is there, but we also need to have a manager who will analyze this and maybe collect some depersonalized data. This is very important. Some great experience in Cherkasy. Managers tell what you need, but what to analyze to be done. It's also an important tool. So for us somehow to manage this, we created, apart from the health department in the region, we have these screening centers for us to rely on. we're quite a large region, and not that complicated as Chernihiv, but we require that. So we relied on existing oncological centers, oncological units, people who understood what the treatment and screening was, and they were engaging family doctors and obgyn, but we managed at the expense of local budgets engage all local medical units. First it was a chaos and a lot of fear, like how to manage this, but now NHS is paying the doctors for their results, and yeah. We were fighting for that, for them to be engaged, because for regional money, we actually gave them this resource as a gift. Okay, you have MIS, you can enter the data, great thing, we'll check the results there, we'll observe this, but we broken so many spears, but we already did that many years ago. Papa Nicolau, great thing to be done when it's not done manually, because lab personnel has to carry out 10 procedures, you know, like, I don't know, a lot of manual work. But there is a machine. It can be automatized, and that's not so expensive. So we saved some money, and we managed to buy this stain analyzer. And now we can see that it's not so expensive, you know. The equipment, the expandables, if the machine is doing this, well, it's not that bad. Automatized system to work with liquid-based cytology. I thought this would be a serious, great breakthrough, you know, like a wow thing, like, you know, how, whatever. For our region, because we were reading about the British experience, that they started using this liquid-based for HPV, and you can take one smear liquid and then the HPV. But expendables are quite expensive, so everything. You need to disperse these to everyone, but what we can see now that experienced obgyns use that. And the broad network didn't understand that, so they just used the simple method. Maybe that's something that's great about it. Even there are obgyns who just use, you know, who just give the smear, you know, for the cytologist to check, and for the cytologist it's much harder. Okay, so we need to have this managerial vertical. Everybody was so engaged because the World Bank has like such a strong reputation. Director of department was there, heads of working groups, and many heads of HCFs, and this was something that was like really high profile, and it really resonated with people. Wanted to be like the best, wanted to show the best results, and everyone was trying to show the best results. This monitoring is super important. Cancer in situ, well, this was like people were really analyzing this and gathering the results. We're like competing in a healthy way. Informatization, popularization. So the heads of departments were like competing, you know, they wanted to actually be presented in the media. I thought it was great. So the clinical route of patient, we approved it back then. It was pretty logical. The MOH is doing this today. No spear breaking. We had so many different meetings back then. Working group meetings, so family, doctors, also director of department gave us a chance to launch these meetings for heads of HCFs. In specialized HCF, a lot of functions there, and we also want to add some screening. We have women there coming with no gynecological screenings, so it had to be done. The level of the regional managers. What is important? Training. IARC. So this is something that we were then transferring to family doctors, obgyns. This is our working group. These ladies did a wonderful job. In 1 year, World Bank allocated for 8 projects 190 million hryvnias, and We had all the procurement done. We used everything. Nobody believed that we needed that much money, like only 25%, but we did it. Because our project was like, it took only 4 years. It lasted only 4 years. Cytological conferences, cytologists said that we don't have this like specialty. We're like somewhere there on the edge, but it's different today. We can see that we have the lab service and a lot of attention paid to it. They were doing their job. If they missed something in Poland, they were doing it here, and like then we realized that our qualification is not the worst one. We have different organization structure. The first results. Number of cytological tests, more of these. You can increase number of tests, you know, 1 woman, 5 tests per 1 woman. Okay. Okay, more of detected pathologies. Cancer in situ, yeah, we can see that. Per 1,000 samples, yeah. Or smears, more of quality. This is not just about getting more, but detecting more of pathologies at 0 stage. And we have this ratio here, invasive cancer to non-invasive cancer. We planned 0.6, 0.7, but we reached 1 to 1, okay? So we exceeded even the planned indicator. In the end of 2019, we had some great results. We had something to go to the IRC workshop for post-Soviet countries. The director of MOH department back then, we went there with him, and yeah. Opportunistic programs. If there's no opportunistic screening, then you just waste money. So everybody understood that, yes, we just waste a lot with no result achieved. We had interesting screening leaders' opinions given. Germany and Great Britain, they have wonderful quality control in Great Britain, like when the sample is collected. Even the Obgyn quite often is taking a low quality smear, and we lose this woman, we lose the case. At the level of lab diagnostics, high or low quality. Again, we speak of simple things, just we use the blue color, we lose the sensitivity. You can do it in automatized manner with Papa Nicolau, Germans say. Many screening centers, we had in many HCFs, but no results were there without the quality control. It doesn't matter how many smears you take if the quality is not there. Again, 0 to invasive cancer. This was like the peak of our hopes, then COVID, then you see what happened. People were afraid to actually reach the HCFs. Of course, we understand why. Screening is a mass influx of like people in waves of patients, so you can see that results went down. And full-scale war is a stress, and people are busy with survival. It's not even about examinations and tests. Now it's a little bit different, and we have our indicators slowly moving up, but the curve we can see. So you can see invasive cervical cancer there, the dynamics of invasive to, yeah. So it's better when we have the ratio with early cancer. It's really expensive to treat the third one. The fourth is like less resources because it's already the fourth one. But the third stage with colossal resources, radiology is there, radiotherapy, and unfortunately the survival of patients, it's very sad with the survival rate. It's better to catch like the early cancer. What is already done? Because we wanted to have the national guidelines on screening. We were like trying to catch the train, as I say. I don't know who can monitor this. We also thought, okay, let's personalize the screening. Like one woman has the early menstrual process, you know, like the early menstruation. If we launched this in the general network where all the doctors will see that, the woman will not tell anything about the risks. So you won't be able to properly enter these risks in the system, but screening depends on that. Maybe it's better to have some simpler initial algorithm. The screening algorithm, yes, cytology starting from 21 years of age. I agree, by the way, with Valery. This is not just my opinion. In IRC, there was like a publication, like there was a young, bald woman with a small child, the one who's dying in Britain. I saw the photo, 23 years old, and she's dying because of cervical cancer, yeah? She wasn't covered by population screening, and she's asking like, dear government, why didn't you start screening us earlier? Like, yeah, so very sensitive publication, but we can lose young women because of this. Some percentage of young women. This is sad truth. Simple cytological screening, starting from 18 or 21 years of age. And HPV when we have 30 plus. It will be easy to monitor. Directive department just tells, okay, this district has completed that and that district no coverage, and there are managerial decisions. 2 slides that amazed me. So we formulate recommendations today, and I checked the publications and orders. We use the classic typical recommendations we had like in 2014, 2015, but we have other publications now where they're not very satisfied with HPV. They want to go back to cytology because there must be morphological change, not just some virus and it's there and not causing anything. And effectiveness. We can sit in good hands when there is quality control. Cytology is not worse than machine-based HPV screening. This also should be like, we should consider that. And quality control, because we have British data when detection of CIN3 is almost the same in HPV and cytology, but very good quality control is crucial. If any questions are there, I'll be happy, but I'm already stealing a lot of your time now. Okay, colleagues, we have only 5 minutes for Q&A. Just be mindful of this. Interesting presentations, and if there are people... Okay, Miss Laura wants to say something? I have a question to Valery. Thank you so much for being interested in introducing the cervical cancer screening in Chernihiv region. If I understand correctly, the patient's route with self-sampling, the patient herself is collecting the biomaterial, goes to a doctor, a family doctor. This family doctor sends the material via Ukrposhta to the lab, okay? Am I correct? Okay, via the family doctor. Why can't the family doctor extract that, collect this, okay? It's impossible, like, per se, or... This is not even a question. This is a very sensitive precaution. Okay, I want you to be cautious with self-sampling process, because I was introducing the screening, HPVs, screening in private labs in Ukraine and even abroad. Look, I know how sensitive PCR test is for HPV when it comes to the quality of material collection. It's critically important. PCR test, despite that is highly sensitive, it may be completely ineffective even less effective than cytology if the material is collected improperly. The PCR testing problem in Ukraine is that we don't have a system of quality control for PCR tests at legislative level. For the sample collection, when it comes to PCR test performance quality control is intuitive and voluntary in PCR labs, at least the state-owned ones. So, from my experience, what I know, teaching 100 of doctors to collect material properly, biomaterial, it's hard, but it's much harder to teach 45 million women, those who will self-sample, okay? Technically, this is hard to collect it properly for effective results, okay? So I think that Ukraine is currently not that ready for self-sampling as a concept, and in the countries where self-sampling is introduced, it's introduced only when there are these multi-year screening programs and effective awareness raising for the patients.
And the mentality of the patients is a bit different. The mindset is a bit different. You see, we had just 5 minutes. You see, they are more attentive to their health. For Ukrainian women, unfortunately, that is not the case. So please think about that. Maybe there is an opportunity. May I explain something? You see? For sure, you ask the right question, the right person. What you're saying about the efficacy and the quality of the assessment of HPV tests in the laboratory. This is the pathway we're taking. We know about this problem. There are the initiators. By the way, we had a few meetings, and in our committee we had a few meetings about this topic. We understand that and we progress in that. There are private laboratories saying that they are the best. There are state laboratories saying that they are also just as good. So we know about it and we know that. And self-sampling. I showed it on the example of Cherkasy region. And in Chernihiv region, we have family doctors, 63%, and 70% of them are of the retirement age, to train, to retrain, or to make them follow some methodologies. With all due respect, the next 3, 5, 10 years, it won't be the case. And ideally, in each village, there has to be the obstetrician, gynecologist, gynecological chair, and so on. It would be a perfect situation. Then we would know for sure that everything is done the right way. But in this case, we adapt to the realities of our time and our capacity and our resources. That's why this is the cheapest and the simplest, probably the most effective way that is there. So as of today, we cannot come up with anything better. With the implementation of the quality control system in PCR laboratories, I'm happy that in Cherkasy in Chernihiv CDCP, this system is being implemented and it is quite effective. Thank you. May I also comment? I'd like for each participant of this meeting not to leave with an opinion that our laboratories work based on intuition. No way. The system of laboratory tests is built in our countries exclusively on ISO standards, which are in every laboratories which have PCR tests. And ISO standard is the standard that does not let intuitive work. So it's all about standardized procedures implemented in the laboratories. The laboratories of CDCPs already have the certificates. 17025 And the second standard, we are going through the accreditation process to get the second standard. So quality control is the foundation. And in terms of the reference tests and research, this area is regulated, and the list of the reference laboratories is highlighted by the Ministry of Health according to some criteria and orders, and there are specific reference laboratories working on quality control and researches in other laboratories. So this system is truly on the highest level, and governmental control and support of this direction and its development, taking into account the financial investment from the state to provide them with additional equipment and everything necessary, like it ensures the full functioning of this cycle. So that's why Valerie Zub says that these tests, researches, and data quality, all of that is based on what the state, the government has done. Thank you. I have to say that unfortunately the quality control of PCR tests is not implemented all the way, and it's not effective. It is a problem and it needs to be admitted. Sorry, inaudible. The speaker does not use the microphone. Lunchtime.
Де описана методика забору? У нас в документах немає цієї методики. І в прототипах, які ми брали за основу підготовки наших стандартів, немає цієї методики описані. І ми зараз цим питанням постійно кнути в голові у людей. Вони будуть боятися вже брати будь-що. Якщо ми говоримо про те, що ми не можемо брати, бо ми неякісно зробимо. Як якісно?
Колеги, будь ласка, ми встигнемо пообідати і встигнемо. Давайте зробимо спільне фото. Якщо в нас є
Before lunchtime, let's take a joint picture. I am here, so please join me stand next to me so that we would have a picture to remember that today, once again, we spoke about the strategies and we move towards the cervical cancer elimination. Let's take a picture to remember this day. Please, everyone who is here, do not be shy. Laura, Tatiana, everyone, please come here. Valerie, we're waiting for you. Elena, you are also interested for everyone to be here. I'm still holding on to the mic. Everyone is here. Just a sec.
Говоріть нам, що ми робимо. Ми не можемо зараз без інструкції.
Всі мають бачити камеру, да, там от другий ряд.
Так, ага, тут все, що все.
3, 2, 1.
Розпуста.
Техніка сьогодні. Зараз 3 секунди.
Повертаємося через 45 хвилин. Я думаю, що на обід все одно треба, бо ми ж спілкуємося, де чому потрібно. Колеги, хто тут у нас вже зібрався, дякую за спілкування за обідом.
So, colleagues, thank you for coming back on time. Let me announce our next panel discussion. Right now, people will join us. So we have 40 minutes for the next panel discussion, and we will discuss the strategic vision. We will share the reflections related to the previous presentation, and then we will have the panel discussion. Let me invite Yevgeny Gorokh, the head of the Department of Work with Digital Medical Data of the Department of Strategy of the Universal Coverage of Population with Healthcare Services NHSU, then Tetiana Tatarchuk, I do not see her. Marina Pavlovska is also joining us. Tetiana Rabina, Deputy Head of the General Director of Public Health Center. She will be in the first panel discussion, not in the second one. And Valery Zub, he's not here. He will join us maybe later, so we are still waiting for a few participants. I will call them to join us.
Я набираю, Татарчук набираю, а Сорочан зараз теж набираю. Ніби вони... О, пані Тетяна, я вас бачу, ми вас чекаємо на панельну дискусію.
Tetiana, we're waiting for you here in the panel discussion. Tetiana, I can see you. I was trying to find you. Also, we need to find Valeria Sorochan. I'll text her. Tetiana, please join us here. Halina, so probably this session is after you, right? No, I'm the moderator of this session and you will moderate the second session, right? So, colleagues, I've just introduced our panelists. So let's start from question. All in all, the first question is to Yevgeny Gorokh, but if there are any reflections of other panelists, participants, feel free to share them. One of the questions is the monitoring and the sharing of data in the system of medical data. Chernihiv project has shown that it's difficult to do that. Your previous colleague said that some monitorings are conducted, but the state has to understand the prospects related to the monitoring and screening of the patients, how to track that, whether it's possible to do that in modern conditions. So you have 3, maximum 5 minutes. Yevhen, over to you. Thank you, colleagues. Well, you see, we have the digital health system, e-health system, which registers actions of the doctor, what is happening, what referrals were issued, what were the diagnoses, and what healthcare level was there. So all the information related to the screening patient pathways, it is reflected and registered in the e-health system. So the examination of the family doctor is registered there, the laboratory tests or cytological tests are registered there, or HPV test results are registered in our e-health system. So any moment we can check how many tests were provided to whom and in what regions. We will probably have some issues and misunderstandings in the definitions. We need to understand how to define screening, what research, what test can be considered as a screening test, to what patients this screening has to be provided. And of course, we'll have to work a lot with that, because even if we formulate our request to the database, we need to rightly formulate that. So we need to be able to find and filter all the patients by age who received that type of test. Then we need to filter like by different codes, different stages of the disease, but the first record in the database will be something like that. And here we face a lot of points, like what age should we consider, from age 21 or not age 21? Do we need to understand in general the total number of patients that year, or only the patients who had some tests or had the reasons to do the tests, or some other situations? Or do we need to learn about the patients who were referred by the family doctor, or maybe they came to us by self-referral, or maybe they got this test because of the other disease in the inpatient unit? We will need to find the answers to all these questions in the e-health system if we want to analyze some data for analysis or something like that. So please pay attention to the need to define what screening is and in what context and in what period of time. That's an interesting comment. I get it that you're saying that there is some data, but if we analyze some data, this data, I'm not going to comment on that, but maybe participants have some questions to the panelists. As of today, we have clear definitions of screening. This is regulated on the legislative level. And here, there may be two, there may not be, there can't be two answers to answer this question. So probably your comment is about clear technical element that we need to have the specific task, so that the data which is available could be used for the analysis. What we have in the e-health is sufficient. So anyway, we need to understand how the doctor or the facility can get the generalized information for work to understand the progress related to making this service available for the populations that signed the declarations with that facility and family doctors, and the medical systems cooperating with e-health. They make it possible upon request to provide this selection and filtering for internal analysis to understand the efficacy of the indicators and achieving the indicators of screening programs. On the other hand, if you choose to improve some mechanism and which will make it possible to formalize and systematize this process, then everyone will be ready and the Ministry of Health will be ready, taking into account the information which has been collected for many years and the problems that are there. So we've discussed and said that the main problem as the result, how to put this result after the laboratory test, how to match it with the patient's profile, how not to overlook that so that this patient would get the services on the specialized level. First of all, we're speaking about those who can get lost in the system with this problem, because early detection, what we're speaking about, we put all the efforts to timely detect and prevent the critical consequences of the severe forms. I think that everyone will join effort to have high quality results, because data is important to make any decision right away. I can say that I don't quite agree with you about the fact that there are definitions, because I looked at the standards of screening, and every time when we or analysts or MOH or other stakeholders formulate what is the screening, my experience says that like some population lives in some territories. Right now, we don't even conduct this quantitative assessment during the martial law, but on the level of the healthcare system, the logic is the following: the number of declarations. So if we think that the family doctor or the health facility provides the screening, then it can provide the screening to the number of patients that signed the declarations with them. But these patients may live in the other territories, and some patients living in that territory may not be familiar for that health facility and family doctor. We don't follow the territorial principle, so right away we have to differentiate the population screening of the territory and the screening which the facility provides for the patients that signed the declaration with that facility or family doctors. And on the level of the health facility, for example, the patients may be familiar, and of course it's an easy to get result to start from this direction. In this case, there are fewer problems. So what I mean, if this patient gets some test, even if it's in the other city, other region, not following the referral of the family doctor, but following self-referral, it will be reflected in e-health system, ESOS, and if there are some test results, it will be put there. And the family doctor will have a chance to see these results, and then we may have the philosophical discussion. If somehow the patient self-referred and bypassed the family doctor, if some specialist recommended or not recommended, and got tested, should we believe that this is self-referral or screening? Because a lot of procedures are formally conducted to get the results. That's one of the components, and we need to define what is screening. So, if the patient got the screening, got this procedure, then of course the family doctor will not refer the same patient to get the same procedure. So also Tatiana highlighted that the main aim is, if the doctor suspects something, we shouldn't just note that +1 screening in our system. We need to help this patient finish this patient pathway to eliminate this problem until it's still cheap, both for the patient and the state, and so on. In this case, this information is actually in the e-health system, ESOS information system, and we don't need any special form like cancer forms we have. And for example, here we need to understand what next steps have to be done. For example, maybe the oncologist, the specialist, the laboratory probably has to diagnose and define how to inform the patient, or should the family doctor inform the patient about it? If that's the family doctor's responsibility, it has to be highlighted, and one of the efficacy indicators may be the number of patients with specific test results who came to the specialized healthcare facility within a month or 3 months. So then we will have to think about such indicators to understand then again that maybe the patient will listen to a doctor, and maybe the doctor may not have the opportunity to contact the patient if the doctor didn't refer the patient. All these steps will impact the screening and any indicators we're trying to analyze. Okay, so let's note that getting closer to the end of the year, next year we will have the new standards and requirements, and together with the stakeholders we can think what data we can collect for 2025, and we should hope that this data should be available and it has to be connected with the target of the state, the implementation of the screening program. So data and monitoring is really important. Thank you for your proactive position. And right now I'd like to give the floor to Valeria Sorochan to share her reflections about the previous discussion. And there was a discussion, there were presentations, some topics were discussed. We spoke a lot during lunchtime and coffee break. So what do you think about the further expansion of the cervical cancer screening, about the roles, responsibilities, and plans of the ministry? Thank you for your question. I'm not gonna try to be original and about the roles and responsibilities, all of that has been defined. All the regulatory framework is adapted to that. We have Order 504. Also Order 1368. Everything is defined. In 504, screenings are stipulated. In 1368, the pathway is described. Where should the patient go? We have the primary and secondary prevention according to that order. The primary prevention is related to women older than 21, and the secondary prevention is related to the age group 30 plus, and by providing PCR testing. So if we get the negative result, we follow this pathway. If we get the positive result, we follow this way. Everything has been already defined. And according to this order, we can see that primary and secondary prevention is provided by the primary health care specialists and workers. The only thing I can say, we can speak about the population screening or analytical data only among the patients who signed the declarations with the family doctors. If they haven't signed the declarations, we do not try to catch these patients in the villages and remote areas. We can speak only about the patients with declarations. But to sum up, all the roles and responsibilities are defined. There is the standard of medical care, 2 orders which are absolutely regulated and synchronized. Everything is done according to the national strategy. All the tools have been provided. So how the facility will do that is up to the facility. We do not limit any facilities. The facilities do it the way they want to do it. But now let me tell you the next point. I really like practical examples. Not to take a lot of your time, I'm not gonna take my phone, but it was last week when my family doctor texts me saying, "Hello, Valeria, I made an appointment with you, and you have the referral to such tests which you have to do annually, and there are some tests according to your age." It's not about prevention. It's not about screening of something. I mean, in terms of the opinion of the Ministry of Health, every doctor knows his own pool of patients. Every family doctor, therapist knows own patients. The group cohort of women of the age group 21 plus who need primary prevention and those who need secondary prevention, well, the family doctor knows these women because my doctor knows about what tests I have to take annually, what I have to get. So according to the screening and early diagnostics of the cervical cancer, it's the same. On the regulatory field, everything is defined, but we can speak only about the women that signed the declarations.
So the ministry has already worked. They did their job. Okay, that's a clear message. MOH is shaping the policy. Quite often communities are implementing it. 2 comments. After the comments, well, right now I'd like to pass the floor to Marina Pavlovska at the level of PHC, primary healthcare. She is implementing the policy. And she, in fact, she can reflect, yeah? Like, if the policy is formulated, now it's about implementing at the level of HCF, department, community. Yevhen, you want to comment? Briefly, I'd like to answer the previous question. I'll be super fast. When Tatiana noted that, okay, we have really talented department directors. We have a big country. We have different cases. When you asked us what to do, truly, these are managerial decisions that MOH can impact. Okay, it can happen there. For the rest, it's done. Okay, so if there are some questions, ask us, and we will try to help you. We'll try to contact you with Cherkasy, to have the communication. There is some policy. We will help you to implement it. Well, this is MOH. This is about ministerial decisions. Very clear. Thank you. Now let's do it one by one, okay? Tatiana, yeah. I'm interested in your patient's experience, okay? You had an SMS from your family doctor where she told you, where she actually sent you to a certain type of test. Okay, is that a proper route or not? I'm interested in that as a manager. What can the doctor do? She has to what else would she offer? No, I'm grateful for that, because I would never even recall that I should do something, well, because I'm already at a certain age. No. I'm super satisfied with that. This is an example that PHC level is doing its job. So she actually, I got the SMS, I had the referral, and she also sent a duplicate for me not to forget. When we start assessing the effectiveness, on the one hand, doctor, she did what she needed to do. On the other hand, you can give her a better indicator. If you go to the test, they'll say, oh, I'm busy. Then it looks like she did what she could, but the indicator is still not increasing. Let's come to reality. Screenings are colored in green only with these referrals. But what is the solution for PHC? You need a microphone. That's obligatory today. You can share your microphone. Thank you for joining. We were searching for you. We found you. So, what is the reality, the PHC reality in that area? Hello, everyone. I'm so pleased to join you today. I apologize for being a little bit later. I was a little bit busy due to... Well, I was busy at the ceremony dedicated to our professional holiday. So, for the PHC level, it's so nice that Valeria received that notification. Trust me, many people get it. I don't know if someone else did. But, yeah. But when the center's managers understand who they are, what their mission is, they do that. Of course, I should know that quite often we stumble upon dissatisfaction. Well, patients are dissatisfied. What you're doing in my e-record? I don't need any referrals whatsoever, calling us and saying that we're manipulating. They think that we get extra money for that. So it's they think that this is a type of abuse, but no. It's informational policy of the facility, and we have to work with that. Yeah, when it comes to screening, first of all, unfortunately, it doesn't reach family doctors that fast, okay? The process standardization, healthcare standardization and services standardization. Out of 504, they've added the cervical cancer to it. Not all doctors are still okay with that, but the process, it's on the way. As we know, at the level of PHC, the task of screening is considered to be complete according to our guidelines if electronic referral is issued. We understand the mission. Not always it's enough. And we are super active. We stimulate patients. We want them to use these referrals. We want them to undergo the screening. But what is the reality? I opened the dashboard in our center, analytical report of PHC provider as of July 1st from NHS, where the dashboard we have on these referrals. We have the performance level of 80%, 90 for all the screenings. Where? The completion of referrals? 2030. Okay? In different areas. Unfortunately, the same situation is with cervical cancer. But we have some optimism still. It's a little bit better because the awareness, cervical cancer awareness is higher. Patients, women go to gynecologists, they know they have to do it. Not always they understand why and what will be done there, but they know that you have to visit a gynecologist like once at least in 2 years. Compared to mammography, nobody understands what to do there, why we need that. It's a little bit better there, but what actually affects the referral completion result, not always when you have this referral, the diagnostic report with the pap test result, not always it's like completed. I hope it's not 30% but better, but still something to work with. What else I'd like to offer for the broader public, let's say. We have the risk factors. 504 order and standard, screening standard tells us we have to survey all our patients once in a certain period, depending on age, send them to screening. But these factors, risk factors, are a little bit specific. Okay, it's like you can't ask just sporadically a person, and not always patient will tell you the truth to enter that in e-health. Second nuance is about the following. These risk factors during the patient's lifetime, these may actually change. These are volatile. It's not like you fill out the questionnaire one time and these stay in e-health for a lifetime. You have to update it. There is a proposal to the ministry. I don't know if we have people from NHS. Okay, good. Wonderful. Let's be initiative. Let's give a technical task for MIS for them to introduce a questionnaire at the level of patient's application, where patient will be able, when one initiates an appointment, one will fill out the questionnaire. This will simplify the job for family doctors because 15-20 minutes for an appointment, well, you don't have time for questionnaires. Not always you can check electronic records and identify all risk factors. It would be super great if patients came to appointments with the questionnaires filled out beforehand. Some basic information for doctors, opening the electronic records, and can see the red flags one should notice. This is all for me. Marina, I'm super grateful. Okay, you raised a whole layer of problems now. Thank you for being positive, and thank you for your reflections on thank you for this realistic assessment of the situation. And I'd like to pass the floor now Mr. Tarchuk. Tatiana Tatarchuk. Her contribution is super important. We've been talking a lot about that. You were sitting there and we were thinking with colleagues that your contribution is huge in standard design. I will not ask questions because you are well aware. What will you tell us? How can we progress? How can we move further? What should we stand for when it comes to cervical cancer screening? Unfortunately, the mic is off. Okay, that's a good question. If we merge everything that we have in our standard, where it's clearly put like the algorithm of actions, it says obligatory and it says desirable. So when you speak of obligatory, woman of 35 plus of that age, if she has risk factors or not, she has to undergo the primary HPV test. Or if NHS covers that, then general referral to cytological test. And again, we have to be sure that this is of proper quality. If woman is of age 25 plus, and again, we speak about obligatory, okay? She must receive a referral to cytological test, again, if it's not Romanovsky, if with proper quality, or the HPV test. And then we have these optional things, okay? That's why we need these questionnaires, surveys, risk factors. For example, but an optional 21 year of age. At the age of 21, if she has risk factors that are contained in the orders, then we refer her. If she doesn't have these, we can save money in this case. It sounds cynical, but okay, maybe it's a proper thing to say. The same thing about women of 25, 30 years of age. This age gap, if there are risk factors, we can then undergo HPV diagnostics after 25. No risk factors, we'll just leave the cytology. Cytology once per 3 years. Cytology 1 per 3. HPV obligatory 1 per 10 years. Optional 1 per 5 if there's risk factor. That is how we combine all these documents, all that. We then have a package. I support Marina. Maybe an app. So we have this global experience and we have the reference on the standard. There is an appendix that looks like a table where there is a calculator, okay? And this calculator, it exists, but as of now, it's not validated in Ukraine. So if we could validate the calculator in Ukraine and allow to use that, that would be great, because there they have certain indicators when she had the screening, like in the rest. It's an interesting tool, but we weren't even able in our standard to give reference to that calculator because it's not validated in Ukraine, So we gave the tables, and doctor can use those tables as reference. This is just the comment because it was important to understand it. Again, when we talk about those that we signed declarations with, if we were able to examine properly and get feedback, get results, not just generate a referral. If you generate a referral, we don't know if patients actually went there or not. If we got the actual result, then we would understand what to do with that. That's where we need to formulate who should get that result. Family doctor should, and under the control of family doctor. And then it's the task of family doctor. One should get the result. If this is HPV or cytological screening result, if it's okay, if it's normal, we say wonderful to doctor and the patient and say, depending on the group risk, next time you visit me in 5 years, or like in 10 years, or in 3 years, you may visit me. If there are some changes, we will refer the patient to the gynecologist, not to oncologist, people, not to oncogynecologist. The gynecologist as a second link in the chain, and gynecologist is, again, the abnormal result. It clearly guides the gynecologist what one should do. If we could enter this, put this in the MIS, colposcopy only after we had the triage examination, or after the smear, or the triage examination with the normal HPV smear, because colposcopy is covered by NHSU. We spend state funds, but the doctor must not carry out colposcopy and spend money when one has no basically reason for that. If we had this algorithm there, if we had this algorithm step by step, that you will not be paid for colposcopy if you will not enter the cytology results and HPV results. If cytology result and HPV result, HPV patient positive, ask us with a cytology. Yes, then you can have a colposcopy, you will be paid. So again, this is for the technical service and the algorithm itself, because the order formulated that, but now we should put that in practice. What happened in 2025? Some positive things that we have in 2025. Our population is aware of what HPV is and what is cervical pathology. So erosion, cervical erosion, we don't treat erosion anymore. Even my daughter-in-law, she's not a medic, she says, oh, Tatiana, you know that there is no such thing as erosion, cervical erosion. Gynecologist told me. Finally, we won that over. we finally have the result, and I'm so happy. Imagine my daughter-in-law even knows this, like it doesn't exist. So, as Valeria says, patient's feedback. This is my patient's feedback. We all are patients, you know, this is a great feedback, a positive one. Gynecologists today know that there's no such thing as erosion. Doctors, well, patients, people understand that there's HPV. We had a study, we surveyed people, we surveyed teachers and surveyed moms and fathers, and even fathers of daughters, you know. They understand that this is quite a problematic thing, but they're very cautious about vaccination. They think that this is someone's problem, but they never assume that their daughter may have sexual intercourse with someone. Yeah, it's about some other daughter, but not about their daughter. They don't even assume that. So in theory, that may happen, but they are not ready to extrapolate. So we need to have a lot of awareness raising for that. There is positive attitude to vaccination. Yes. Our people have positive attitude to vaccination. Understanding of screening, it's still not there. People still think that this is like this annual examination, like ultrasound, gynecologist. I don't know why, but I have to. But the visual cancer type, to assess the visually the type of cancer or the precancer, the one we detect when we examine. With speculums, you know, while women are in the chairs, because there are so many instrumental methods. But visual forms today, well, are still not adequately assessed. So thank you so much. Ms. Tatiana, thank you so much for a lot of positive stuff. You actually opened some new horizons. I noted some things. And before I ask our audience, Tatiana Rabina, how will you conclude that? Maybe you'll reflect on that. And my question of the whole panel, how can we expand the capacity of introducing the cervical cancer screening problems? But this is a comprehensive issue, okay? You were shaping the policy, you were in the process, and now you're implementing the policy. And this meeting actually is about reflecting on that whole pile of work that you had with colleagues.
As the joke goes, I take note of all the problematic issues to plan the next steps within the engagement and in terms of engaging colleagues from PHCs and partners who want to implement the screening program. First of all, it makes me happy that all of us understand that it's huge progress that brings us closer to such a difficult point as elimination. Over a short period of time, we've taken necessary steps and we already have results from these decisions, and that's important. So what needs to be done, as I see it anyway, as of today, with this general declaration that we agreed on, all the participants of the process agreed on, we all get it that the easier it is, the more tools are available which make it possible to implement the tasks, the more effective the process of patient engagement will be. So we discussed the necessity to update methodological recommendations, and the surveys and questionnaire forms are one of the priorities, and we will work together with the PHC, the methodological recommendations, which will have the survey forms, because to implement something into the medical information system or any digital tool, we'll need to have the digital electronic framework, which will make it possible to use this tool for implementation. If there are some standardized forms on the use of tobacco and alcohol, then we also need to have the standardized forms on other risk factors. It's a bit more difficult to do that, of course, but this is what the next step has to be like, so that every family doctor and every head of the primary healthcare facility would have a chance to have the standard template or format which can be disseminated, or in case it's needed, like they can use this tool. The second point. About the groups of patients and their engagement. Tatiana rightly mentioned that there is no contradiction in the standards. They are synchronized, and MOH cannot have some discrepancies in both documents. They simply have the information aimed at different groups of patients. Our discussion anyway is more about screening of the population, where age is the risk factor. So for us, it's truly important to start step by step implementing these tasks, because speaking about the expansion and engaging everyone would be difficult. So let's start from something simple, something corny, and like if there is a problem, it'll require a different communication level. The family doctor finds it easier to communicate with the patient, attracting the patient to his or her side so that this dialogue would be successful. Once again, I'd like to reflect on the statement about the screening of prostate cancer screening. We didn't remove that. And it doesn't stop you as a doctor to refer your patients in case it's necessary for this type of screening test. Let me comment. It was excluded from the list because PCI test identifies only 15 or 17% out of the prostate cancer types. So referring patients to this screening, in most cases, most existing cancer types were overlooked. So then again, if we speak about screening, we're not saying about removing this cancer from the priorities. It's just the PCI test that was in the list was removed because it's not very informative. We have a lot of tasks and we need to move forward, so we have the effort of all our team members, and it's really important to assess any results, because here we have the data which can be used, and we will have a chance to assess our efficacy of the decisions shortly. We'll have a chance to do that. We will have the necessary data, and we'll be absolutely sure that we've achieved the necessary results. Thank you, Marina. Thank you, Yevhen. And 2-3 questions from the participants. A brief comment so that we would move on to the next point. First of all, I want to thank Tatiana for the ideas she shared. Let me say right away that about colposcopy, that is not always reasonable. It's reasonable only in some cases. In PMG, we have a lot of points like that. And literally this year, we reached the capacity that we started taking that into account in the laboratory package and the algorithms of referral of NHSU, which provide the details what doctor can refer patients to what specialist, where NHSU pays for that, where it's not reimbursed. So we will consider your idea, we will implement it. One more point that I'd like to say, we are going through the period where we get the feedback from the healthcare facilities. Often it's negative feedback because they think that NHSU doesn't want to pay us for something, and it used to pay us for that. But for real, what you're saying is reasonable, and tomorrow when we are asked why NHSU paid for something that the doctor prescribed, just in case we'll have the arguments to answer. So this is the question to our digital health system, e-health system, and the algorithms of NHSU, identifying the principles of payment in the ambulatory medical care package. And what Marina said about filling in the survey forms here, it's difficult for me to answer. We have the two-component e-health system, the central component is all about data collection, and there we can record and register something, but all the interface and the interaction with the health facilities is the responsibility of the medical information systems, and they have to do that the way they understand it. NHSU may recommend something, but like the health facilities have more advantages when they sign the contracts with MIS, because NHSU may require from MIS so that the data would be shared fully according to the specification identified by NHSU. We can require that, but we cannot require additional functions. So what you're saying that it will be a great idea when we implement this electronic or digital patient's office. So we are waiting for that, and we hope that it will happen. And when we have the tool on the central level where the patient can use this patient's office or portal and change something there and look through the medical records, like then it will make sense to provide some survey form. But when we have this, like before that moment, we will share a lot of reflections and comments. Just imagine that the patient sits at home filling in the form that he or she has BMI, but the doctor will see in the appointment that the BMI indicated by the patient is wrong. So what data should be put there? The verified doctor's information for sure, not just patient's opinion. So maybe there is a template of that the patient fills in, and the doctor has to verify it to save time and put it into the database. I understand how much time it'll take, and when we see that, then we'll have a chance to say where we're moving next. But in general, all these elements are a big part of the information system development, clinical support information systems, which help us make some decisions based on the information, and it has a lot of prospects, and I think that NHSU will work in this regard. That's very interesting perspective to see that working. Thank you, Yevhen, for sharing positive news about the patient's portal and access to the data. So we're getting there. Thank you for the comment. Let's hope that we will have only the best possible scenarios in the future. I think that in the digitalization age and taking into account the approved state strategy on oncological disease, we can start the working group of survey forms, because that'll help family doctors, regardless of the fact that PCI was excluded. And we remember about the lung cancer, which is detected in severe cases in 50% of the cases. Melanoma is very, very also spread and prevalent. We remember that, but the more cases and conditions are there, the more difficult it is for the family doctor to keep all of that in mind. And a lot of the information systems, medical information systems, already have the patient's portal. And also think about this idea: if the primary healthcare level has at least some express tests which can diagnose the pathology of cervical cancer on the primary healthcare level, then we'd be able to implement that. It's all about the necessary equipment and medical supply. So the women who have the suspected conditions, there aren't so many of them for real. So thank you. In the panel discussion, we will speak about the financial aspects of HPV. A comment. Here it's about validization. We spoke about the laboratory service. If we speak about HPV, it's important to have the valid system so that we wouldn't get false negative. If it's false positive, it's okay. We will run the additional tests. But if it's false negative, we need to provide the information. For example, in Ukraine, there are registered manufacturers providing express HPV tests, just like there is express pH test and express HPV test, but it's not indicative because it's not validated and the state will not procure it. It may be just to inform the patient, no more than that, but the state will not procure these express tests because they are not validated, so we shouldn't move towards that. Colleagues, questions? Please raise your hands and I'll pass the mic to you. Not a question, opinions. The head of the primary healthcare facility, I have appointments with patients. You brought up an important topic, and 80% of my workers, doctors, nurses, were in that training. Thank you, Halina. You informed them that it's important because recently there was the forceful approach to cytology and they really like it. So what problems may we face in the location? Well, there are no problems with people with declarations. In 5 minutes we can see the database by doctors. As the head of the facility, I understand I have to incentivize family doctors to work with them, to think of some additional payment indicator. We will have some competition about who will get that incentive, because that's the only way how it works. But we have, that's about the medical personnel. But about women, if women don't feel pain, that if something doesn't bother them, that they don't want to get tested, we lose a lot of women in this group who go through professional examination, because unfortunately cytology is not a part of the professional examination. If a gynecologist takes the swab, it's important for him or her to run cytology. Maybe it's important to change the legislation so that it would be a part of the mandatory professional examination. The swab, flora swab. Order 280, we have hundreds of people who get to this swab because it's mandatory, because they will not come again to the doctor because they will have to work during the study process. One more point. I think a lot of patients will not agree for the nurse or family doctor to take this swab because people think it's gynecologists' thing. Taking into account that in the order it says family doctor or gynecologist, I understand that in our communities we have to make the decision ourselves, while our MIS information system gives us the information who came to the appointment, who didn't. We have to go back to what we had before. To make a focal responsible point who will register the results, and we will see who came, who didn't come, and every doctor will see if the patient came back or didn't come back. And then again, for the women to come, we need to make it comfortable for the women so that they would get this service quickly, and maybe they need to get the information sent by phone, but then again, it's the confidential information. We discussed this in our community on how to make it possible, but for now we still have a lot of questions. For sure it needs to be done. That's all we understand. Thank you. Thank you for your work, reflections. I wrote down your comment, and we will continue that in the next panel discussion. We have the same questions with the same participants. So, colleagues, let's wrap up this panel discussion. We will have the summary a bit later. Right now, let's thank our speakers who were honest, brought up different issues, and shared the desire to work in this field to save the lives of patients. Thank you, colleagues. So we have no break right now. We will just change the panelists. And the next moderator is Halina Maistruk, and she will tell us who are our participants, one online participant, international speaker as well. I think that everyone has to see our heroes. So, Tatiana, thank you so much. You won't be able to leave us in the English style without saying anything to anyone, so we noticed you. And colleagues, we have the second panel discussion, which continues the first one. And I want to invite online speaker Volodko Natalia from Lviv. And we will have the online participant Isabel Hurd and Olha Palichuk, doctor, gynecologist, oncologist, MD, professor of the Department of Fundamental Medicine of Cherkasy National University, and Orest Trill. Once again, we invite you here. So we're inviting all the panelists. Also, Irina Bilous, the head of the Cherkasy Regional Specialized Medical Center. Please join us. Right now we have... So we have Tatiana Orabina, who is the first speaker, but all the ideas she had, we listened to her ideas in the first panel discussion.
And now we're stepping gradually to that moment, we're stepping to strategic vision on cervical cancer screening, evolution, and how to scale up the effective practices. We have a whole bunch of people who have been trying to approach the HPV testing. They have the experience, they have their vision. They have really strong reputation in the community among the obgyns. I can't speak of family doctors now, the obgyns only. And now I think it's really relevant. It's really relevant to think about this implementation based on MOH recommendations with new players, the new screening players that have stepped in January, primary healthcare level. So now we have this question, like, how can we implement these new practices? And I would love to start with Miss Natalia Volodko. So I would love to introduce her as well. She is the head of the oncology department and also medical radiology of Lviv National Medical University. She is the president of Association of Cervical Pathology Colposcopy. So she is actually a large promoter in Ukraine. She's a large promoter of HPV diagnostics. She knows everything about it, and she finds people who help her. She finds the followers. Okay, I have a question to you. How can we increase the coverage of women's population with cervical screening, and how can we increase its specificity? And second question to you, is the system ready? The specialized healthcare system ready? Is it? To have this increased amount of pathologies, are we able to provide women with that qualified support, qualified help? So we're listening to you, Ms. Natalia. Halina, greetings. Do you get my sound very well? Oh, yes, we do. Greetings, dear participants. And truly, the whole previous discussion, I've been listening it since 10 a.m. It actually reflects our accomplishments and difficulties that we have on the way to eliminate the cervical cancer. And as Orest mentioned correctly, yes, you can have a lot of money. You can organize it properly. But if there is low coverage, well, the screening effectiveness will be really low as well. So again, I will quote Ms. Tatiana Orabina, who left already, that the higher the availability of the testing tool, the more effective is the testing. And in this context, I would love to deliver my speech and actually advocate the self-sampling for HPV testing, the method that actually recommended itself very positively, and it proves itself to be effective, evidence-based diagnostics method, pre-cancer diagnostics. So we're not even discussing what's better, cytology or HPV testing. Sensitivity of cytology 50%, and this is the figure, you know, for cytology, for Papa Nicolau cytology, which is not performed in Ukraine. Romanovsky, it has even lower sensitivity. You know that all patients that we were consulting in our recently, the majority of them were included in the screening, and the majority of them had cytological tests a couple of years before they had this severe cancer stage detected. This is a painful thing. And of course, using more accurate one as HPV test with effectiveness, colleagues spoke of that, specificity of it is much higher, 90%. This is obvious. It's pretty obvious. No. Then we have the following question. How can we do that? How can we approach the method? So method of self-sampling or self-collection. This will meet the needs that actually were mentioned by our colleagues from primary level or family doctors. For women, this is confidential, convenient, fast method. And honestly, it's quite a reliable one. HPV testing systems, well, these are dangerous things, okay? Systems must be validated. They must contain internal quality control. It must be there, like rush diagnostics. But the self-sampling or self-collection, many studies that were published and with a comparison of self-sampling and when the sample is taken by the doctor, so completely comparable. As I said, FDA approved the primary HPV sampling. So yes, for us that could be an option, especially within the humanitarian crisis. And the second question, is the system actually ready? The oncological system, is it ready? You know, we have very well-trained gynecologists. We have qualified gynecologists. They know how to handle pre-cancer. We have a whole army of qualified gynecologists. We have oncologists well-trained as well. And it's much easier, you know, to treat micro-invasive cancer than, you know, having these titanic efforts to treat frequent cancer with radiology, with target immunotherapy. We spend a lot of money on it. Okay, it's super expensive. I think our healthcare system is more than ready to treat the preclinical cancer forms. I do hope that we will detect with that method. Miss Natalia, I think that you will stay with us still for an hour or so, because my gratitude goes to you. I know that you have been in this process for years. You are training Ukrainian obgyns, and I know that. And your activity, you're well known in Ukraine, you know. You're a prominent person. I have a question now to Miss Olha Palichuk. So Olha Palichuk represents Cherkasy on one hand, on the other hand, she's also a national expert, let's say. She's an active member of association, and we all know that. Okay, I had this question. Yes, so you have been active for many years. You've been related to oncological service. And I know that women have very strong, how to put it properly, women have fear. They are afraid of oncological healthcare facilities, let's say. It exists, it's there. For example, in your opinion, how would you, okay, they have undergone the screening. We have the results. How can we help these patients? How can we not lose the patients? Okay? Your vision. Is this the territory of oncological dispensary or women's clinics? We have like wellness centers or whatever. Your vision. How can we retain these people, not lose those patients? How can we make sure that they are staying in the system for further treatment? Please, a little bit about economic component of the whole stuff, like is it covered, hopefully? Well, honestly, for many years we've been active in various areas, and this is a great thing that we have associations, not just the associations of oncologist/gynecologists, also cervical pathology, colposcopy association, and the rest. Because updating and optimizing the system of cervical screening and providing Ukrainian women with innovative methods of timely diagnostics and prevention, this is our joint work that we've been performing this work for like 10 years at least. We are, let's say, in our country, we also have producers of medical equipment, medical equipment related to colposcopy examination. And thanks to several state programs and local budgets, we have good coverage of Obgyn service with colposcopes, with other necessary equipment. We have this training system fully functional also for Obgyns on colposcopy. And when the medical reform was launched, pilot projects were launched, screening centers in Lviv region, oncological prevention in Cherkasy. We had women's health centers established. Then we had some error in the system, a bug in the system. When PHC, active PHC reform was launched, and primary level received money from NHS, managers of PHC units and facilities, they started separating themselves from universal databases, because gynecologists and oncologists were like pushing the Obgyn community, saying that, okay, there must be timely diagnostics, we need to collect samples properly, and so on. They were engaged actively in different types of trainings, but after that, we have this boat without, I don't know, so that moves randomly, so there's no sail on it. We are now saying that we need to have this unified electronic system for all the levels, primary, specialized, secondary, to see the results, the testing results for the patients. Not to avoid duplication, not to collect the same samples all the time, because if we're picking the way of innovative tests, like primary HPV diagnostics with self-sampling, what is an important component of it? Awareness raised. So all the medical professionals have to be aware of that, because our medical system is ready for the treatment methodology, our experts are ready for diagnostics, but we have the error when it comes to information exchange. And an important component is primary level, because they want to get new knowledge. They are interested, they're enthusiastic, they ask questions. They're much more interested than Obgyns. They're a little bit tired of that. HPV, they're asking, and the reasons, the causes, why we have these pathologies, and a lot about vaccination they're asking, even now when we finally have it at the expense of the state budget. The focus of our associations, of all of us, in cooperation with the Association of Family Medicine, we started that. We have already a couple of training series in different regions. We do it jointly. It's important because primary component, if we speak about HPV test, it will depend on family doctors. Timely referrals, timely communication with other specialists from other areas. Okay, I'll go back to this question, Natalia. A little bit of economic aspect. Okay, money. A lot of barriers for women there, we hear about that. So, like, the question why they don't have primary screening, they're afraid of further results, they're afraid of expenditures, okay? Time consuming, money consuming, it's quite a pressure, mental pressure for them. Okay, tell me please from your practice, like now, okay? like severe dysplasia, CIN3. If this is covered today, maybe not even by private, by business K, no, but if in the state system it's fully covered, it's duly covered, I mean this whole umbrella, treatment umbrella. And we have representatives of NHS. For us, important it is to hear it now. Okay, the thing is, everything that's in the inpatient for treatment for adults and kids, it's covered by NHS, colposcopy as well, cytological screening, yes, as well. Diagnostics with Papa Nicolau, as of now, it's a paid service. And those HCFs that provide that service. There is no, it doesn't matter if these are municipal or private hospitals, but anyway, all consultative help from obgyns, oncologists, covered by NHS. Sometimes people are not well aware of that, okay? The low awareness, and we have this deficit of staff. Therefore, we all rely on family medicine as our reliable partner that will help us to refer the patient properly according to regional patients' routes. Miss Olga, thank you so much. I would like to introduce Miss Irina Belouz. She is the director of Cherkasy Regional Specialized Medical Center. Miss Irina, you will explain to us what kind of center that is. What are you doing, actually, in practical terms? And I know what you're doing. I just want people to know that as well. Tell me, please, the potential of your integration when it comes to HPV testing. Is it a real thing? Is it an actual thing? Thank you for the question. I am the director of Cherkasy Regional Specialized Medical Center. It has this name for 3 years already. Before that, it was a regional AIDS center. Specifically, like, what is the specific task? So we take care of AIDS patients, co-infections, hepatitis, and so on. Why we are unique, like why the center is unique? So powerful virological laboratory. It was opened in 2019, and currently under the as contractors, powerful contractors, under the agreements, we provide services. 60 HCFs in 5 regions of Ukraine have agreements with us as with contractors. So we provide services. So we speak about viruses, yes? And relevant testing. On HPV, we have a couple of systems, 3 PCR different systems, open, close, Abbott, like that. These are powerful, innovative machines, let's say. And we work with various viruses, qualitative and quantitative, both. So +1 virus, well, that's going to be HPV. That doesn't change the weather, let's say. For us, it's okay. And not a problem. We can integrate in this environment, in this context. Speaking on delivery, well, I'll tell you that we provide services for Kirovohrad, Luhansk, Cherkasy, relocated region, and also plus Odessa city center, plus Vinnytsia regional hospital. You understand that these are distance. These are different regions. Delivery by mail. In the evening, in Odessa, they put it in a car. In the morning, next day, the driver takes it, and by next evening, the results are there. 24 hours. We've been doing that for 4 years. We have that experience. So this is a routine, everyday practice, and it was hard to establish that routine. But I'll tell you that 250,000 tests per year. This is our capacity. We have International Certificate of Quality, 15189. So it's the most innovative standard that exists. And we're in the bidding procedures as suppliers of lab services, providers of lab services. How can it relate to HPV specifically? Well, it's not a problem for us, We have various testing systems. We have validated and non-validated ones. The price for validated, approximately 1,000 hryvnias for one test it's not covered by NHS, yes. The cost for non-validated system will be like 400, 600 hryvnias. We have 3 genotypes there, 16, 18, 45, with differentiation. So what we need is there, but it's not validated. So we have options, basically. If we speak about validated systems, well, you need to find sponsors or engage some, I don't know, procurement or regional programs. It's harder. It's harder, but there are options. They exist. You just have to discuss these, you know, consider these. Maybe as a pilot with non-validated system, experts are for that. I can just tell you how it can be done technically, how it can be organized. For example, almost all of our HCF managers in the region we have in the room, they have contracts with our center, okay? We provide those services. We've had a long history of cooperation. They can send people to us for sample collection. We need samples, we need material. It can be transported. It doesn't require some specific conditions for transportation. Self-sampling, or the nurse, the obgyn, the doctor will do that, whatever. Material that we need in a certain container that is delivered. So like small container, a typical one. So it's delivered, and of course we need to have this electronic referral completed, and then the NHS will send a payment. We'll reimburse that. We have options, but this is a real thing. It can happen. It doesn't matter if we work with PHC, with regional facilities, with secondary level, whatever. Just doesn't matter what kind of that. Yeah, everything, the results, like both in electronic and paper format, it depends on the person.
Please. The key point here is validation. Irina raised this issue because we discussed validation a lot related. We did that during our working group meetings with the participation of the association experts. We discussed validation and the types of genotypes which will be tested by HPV screening. And like we take only highly oncogenic or like all of them. So this is the topic for a discussion because funding is the economic component, you know. Yes, you know, first of all, I want to congratulate you on such great center in the city of Cherkasy, and I think that the community, doctors community, is so active, and it'll find additional funds for the colleagues to use the validated systems, because the use of non-validated systems is like cytology, which provides false results, and then people will say HPV testing is not the right thing to do. So I think that colleagues should use validated tests. Like when we speak about DNA testing, it's also important, and just like genotype 6, 18 and other types, if there are 14, not 3 that are tested, it makes a difference. Thank you, Natalia. That's a very, very long story in oncology and everywhere else. Generics and original medicines which have to be used, it's up for a discussion. And of course it all gets down to the resources, financial resources. I always say that maybe in our system of coverage of population, even in Kyiv, in the administrative times back in 1980s, when we couldn't go on holiday without the screening, the coverage in the city of Kyiv didn't exceed 45%. And it was a good result. Of course, a lot of that coverage was a bit fake, but still, right now the coverage of population is extremely low. And if we do something, we have to do it in a quality way and the right way. And how to cover people with the screening and tests. We know how many people do not get tested. Although those who get tested, they have to get the good quality tests. I absolutely agree with what you're saying. So I think
Sorry. Can you hear me?
Yeah, we hear you.
yes, please.
Yes, I just wanted to, I fully agree with the idea of only using a clinically validated test. But I think that what is important is to understand why we should do it. A clinically validated test is a test which becomes positive only when the threshold of HPV infection is as high as it can produce a cervical lesion. If you use a non-clinically validated test, it can be positive when there is only 1 or 2 copies of 3 or less than 10 copies of HPV. So you'll have lots of women who will be HPV positive, just like that. And this infection is not relevant to a cervical lesion. So I think that's very important to understand that. If you use a clinically validated test, it will only be positive when the threshold of HPV is as high as it can produce a cervical lesion. If you use a non-clinically validated test, maybe it will be cheaper, and the industry will make it, commercial will make it easy for you to use it. But you'll find thousands, hundreds of thousands, much more women who will be HPV positive with only very transient infection, non-relevant for screening. When we say clinically validated, it is clinically validated for screening. So I think that's important to understand that and to discuss with our colleagues, because in the world of virology, our colleagues in virology, they always want a test which is positive at 1 copy. When we were with COVID, when with HIV, we want the best test that identify 1 copy of virus. But for HPV, it's different. We want a test that is positive only when there is a risk of lesion. And this is what clinical validation means, that you will have thousands of women who will be tested. They will all have a colposcopy. Clinical validation is that you have thousands of women tested, thousands of women with colposcopy, and then you identify the threshold of positive test according to the result of colposcopy.
And finally, it will be more expensive. Finally, when you look to every expenses for the patient, it will be expensive because you need additional treatment and diagnostics. Yeah. Isabel, I will come back to you again after Mr. Orest. Мене запитання до Ореста.
I have a question to Orest. I'm really impressed with your presentation because not very often in Ukraine we can hear about what was happening 10 years ago. It just happened that way. We don't often retrospectively look at some results. So I heard in your presentation the following statement. First of all, you said that there are ups and downs of the interest to screening from women. So we have national documents, I mean the necessary decrees and orders on the national level. We have financial resources. We have the air raid siren, but we are in the bomb shelter already, so we can continue. Sorry for this interruption. We have the air raid siren in Ukraine right now, so. It's just an announcement for the residents that there is air alert or air raid siren. So, do you forecast that this interest waves will continue, or will we somehow reach the plateau, the stable screening work? I hope that there will be the increased interest from women to get screening, and we can see that women are more and more interested, and family doctors say that the gynecological screening has to be mandatory, and it's great that the family doctors advocate for gynecological screening. And I have a few comments to share. I think that it may change, the interest may go up. A lot of things have been said about quality control, about HPV. We are just starting this work, like how many types we will test, how we will understand the sensitivity, and how we will identify that sensitivity. Of course, a lot will depend on the financial resources from the state, which will be allocated. And of course, we want to test for as many risk HPV types as possible. So we have about 1 million women who are screened in the region. Even if half of them get screened, of course we would get great cytological swabs for this money. Of course, the fluid cytology can also provide great results, and you can provide this material for HPV diagnostics. But in our region, we didn't have all these financial results, and we were simply using the Pap Nicolau classical coloring and the simple swab. And we need to think that we need to do something not to lose everything. We shouldn't debate between cytology or HPV testing, because if HPV testing is positive, the woman goes to gynecologist, and anyway, the gynecologist runs cytology. Yes, but cytology, like, they will be more specific and of higher quality. They will be quantitative. And here I look at Yevhen. We know each other for a long while because we work in the cancer registry and database together. It's important to understand if the swab is of high quality, poor quality. So how many family doctors or gynecologists get the poor quality swabs? We don't have this personalized database, but anyway, we know that it's the case. And the cytology is done the right way, and the patient comes with cancer condition. So maybe cytologist didn't see that, or maybe the swab was of poor quality. So how can be done? How all of that can be done, but without the transparent system of monitoring, it's impossible. And we have to have good data collected. I heard somewhere that the family doctor have to be incentivized for providing good quality swabs, and like if you can somehow compare two doctors' quality in your facility, that's great. But on the level of district or region, we're like paralyzed. We cannot compare anything because we cannot integrate all the data from 3 medical information systems. NHSU, National Health Service of Ukraine, is not ready to provide us with the dashboards to compare some indicators among the facilities. And then we have to take the women who got the referral and didn't get tested. We need to invite them again to get tested, to finish that, to close that referral. And we need to think how to make it possible, because from the general indicators all the way down to the personal indicators, we need to keep on inviting the women for the testing all the time. We have the army of trained gynecologists. I support this statement. Well, right now, women go to family doctors and they go to gynecologists only if needed. But you don't really need to get the referral to gynecologists to have an appointment. Yes, the gynecologists are trained, but people need to go and get their services. Why the woman doesn't want to go to an appointment with gynecologist? If we take if we give the woman the self-swab test, so that like she could do self-test by herself, maybe it would be easier for her to do that than to go to the gynecologist. But will the woman actually take the self-swab or not? Because she may be scared to do the self-test, because she may be scared that she will be called to the oncological center. There are so many different fears that the woman faces, which are the barrier for her not to go to a gynecologist or not to get a screening test. We need to raise the awareness of women, saying that if you run and if you have different if you get regular appointments, then you will probably not have the cancer. You will reduce the likelihood, because the woman may hear that her neighbor went to gynecologist, got the diagnosis of cancer, and in 3 years died, and she will not go to an appointment with a gynecologist because she'll remember that story and will get scared. Okay. If we have good statistics, good coverage, engagement of patients, good examples, you know, in the USA when the president's woman got sick and she said that she has breast cancer, but she got treated, and she popularized this case and encouraged all women to get tested for breast cancer. But we don't have a lot of cases like that where celebrities also speak about that. So we have to share these cases where women can treat minor cancer forms with low risks to life. We have to show that, and we need to change the attitude of women, because when they, for example, teachers in the schools, they have to get professional screening and examination from different doctors. So we need to include this screening into it. And the screening test, first of all, has to be cheap, precise, and so on. Precise, first of all, not cheap that much. So, also, one more comment, and then we'll give the floor to Isabel. Everything works when the team works, and information policy, information campaign is important, and positive stories from oncology patients are important. Family doctors rightly said when someone dies from cancer, half of the village arrives. They are not scared and arrive to the funeral, but it's negative case, but we understand that we live in stressful times because of the war, and women may have different problems because the relatives may serve in the army, be a defender. Maybe some are injured, they have to bring up their kids, so we need to find other approaches to inform the population. No way we should not scare them. For example, with Irina, we have multi-year great cooperation related to HIV patients. HIV patients are stigmatized. It's a very difficult group of people to engage into examination, into vaccination, and in general, they are the risk group for severe dysplasia and cervical cancer. But anyway, if we can work with HIV patients and we build trustful relationships, they are not scared of gynecologists, oncologists, than with the woman who has no severe pathology, who is just in stress or has some financial issues or family problems. We may probably find a way to communicate with her via family doctors or some all-national information campaigns. Thank you. One more question. First of all, I have to give the floor to Olena Kochuba. Before lunchtime, we didn't kind of let her speak, but she's reaching her hand to the sky already. So I have a question to Orest from previous session, but it matters still. When you ran your project, you had additional funding from the grant program, and you said that you procured automatic system for cytological tests, cytology. Did you procure only one system and right now you run centralized screening, or did you procure a few screenings? Was it fluid cytology or classical Papa Nicolau? And follow-up question, and when you said comparing Germany, there were some questions related to the fact whether HPV test can replace cytology. It's not about replacing, it's about co-testing. If we identify positive HPV test result, then we take this positive test result, we use Papa Nicolau cytology, and we get the necessary result. Main questions were like that. Can you hear me well? Right away, we procured the system for fluid cytology, and we put the automatic line so that everything could be drawn and the result would be given. We even thought about automatic results, but it was very, very difficult thing to do and expensive with like photographing of the test results. Our cytologists also were good at that, but our laboratory workers were overworked when we implemented classical Papa Nicolau, because earlier everyone used the same color for coloring, but we wanted Papa Nicolau. And it's a more complex coloring system, and we bought a staining system. So, like you put some device from one hole into the other one, and in the centralized laboratory we don't have so many cytological laboratories, so we have a few centers who have cytologists and they were manually do the staining, but we also tried to use Papa Nicolau, and mostly Papa Nicolau staining is used more often. So it's not about replacing something, it's about responsibility, honesty, and maybe additional funding for the stainer. And you know, because these colors are not more staining elements are not way more expensive. Thank you. Thank you. Orest Yevhen, you raised your hand. Thank you. In the discussion, we heard that NHSU doesn't pay for pap smear tests, or did I get it wrong? Because it has to be a part of the reimbursed tests. It is paid for. So NHSU pays for that. I simply want to say that I would consider our discussion about in the regard of population screening. We need to think about our discussion from the perspective of population screening. It's not about destroying the previous system. It's not about building something absolutely new. Worldwide, it's recommended to have both of these systems parallel, taking into account many factors, and preferably in the pilot regions, to understand what needs to be done. We cannot right away say that we had something before, now everything will be different. But what we need, and we speak about it, and Laura also spoke about it despite all the technical issues we faced, but she had a great presentation about the quality, and we will speak not about the quantity, we will speak about the quality. And this is something that we haven't discussed, taking into account that we don't have the automatic system, we haven't discussed the quality yet, we spoke about the quantity, it's just the beginning. But I want to give the floor right now to Isabel Hurd. She will have a separate presentation as well, but she just listened to both of our panel discussions.
Impression from these panels, both, first of all, and also regarding your recommendations for what you hear, because it was raised a lot of questions about screening, but maybe something very prompt, very quick, your impressions and your recommendations. Thank you, Isabel.
Thank you very much. Nice to be with you today. I always like to work in your country with you, and I'm a gynecologist. I'm retired as a gynecologist, but I'm still working as a consultant in WHO, and I've been involved in implementation of cervical cancer screening programs in this part of the world. I have a few quick comments before giving my talk after all what I've been listening to what you said. First, I must say I'm amazed you're ready to start, and that's absolutely excellent news. I have a few comments. First, I want to insist on the way that the best way to have women attending the screening is to empower them, to let them understand what is an HPV infection and how it can be treated. What is very important, I think, at the moment is that we have all gynecologists, all people working in this field, we have to move from the HPV test being the sign of an infection to HPV test being the best indicator of a risk of cancer. So there is no more stigmatization for a woman. She's HPV infected. No, she thinks, oh, well, I've got an infection. Where have I been? Or my husband. Stop thinking like that. just tell them, when you talk to them, you have to have an HPV test because this is the best indicator of a risk of cancer. And I think this will help women to access to the screening. Then, another comment, which is, but you discussed it a lot, about sending invitation for the women to be screened, having a health system information. You talked about that a lot, and I think you're ready to implement it. And then through this system, women will receive an invitation according to her age and nothing else, or only if she's HIV positive or transplant recipient. We always forget that transplant recipients are immunosuppressed, should be screened more frequently. They have the same risk of cancer as HIV-infected women. So there should be an invitation that will let women being tested only when she needs to be tested and not when she feels, or you are the gynecologist, because she has a new partner, you feel she should be tested. And then we discussed it earlier, and Natalia said a lot of things about that, about having an efficient test for screening. Test for screening should be the more efficient one rather than the cheaper or the quickest one, because the cost of the cancer you've missed when you've been using a cheaper or a quick test is much lower than the cost of an efficient test. And you always have to put all that in the balance. Then I had another, I wanted to say a few things about quality assessment and quality control in labs, in all labs, and this is very important. This is the onlyest way to avoid cancer and to have an efficient screening. There is also a new concept. We have lots of discussion at the WHO at this moment about follow-up, and I've not heard anything about that today. Now the big discussion is to follow up post-treatment women, is to avoid the high number of women who are lost to follow-up. And this has to be taken into account when you will implement the system. And then when you are thinking of starting screening women at very young age, like 21, I've heard, you have to be aware that between 21 and 25, the rate of spontaneous regression of high-grade lesion, of precancerous lesion, is very, very high, at 60-70%. So that's why in many countries, many countries, like in mine, in France, we completely stopped testing women before the age of 25. Because when you detect a precancerous lesion at 22, the young women will be very scared. You will not be sure what to do. Should I do a leap? What should I do to treat her? Should I decrease the risk of pregnancy later when I'm treating her? But because in this case, most of the lesion will spontaneously regress. So you should be careful when starting the screening at very young age. And that's, again, why many countries now stop screening before 25. So this is my general comments I wanted to give about all what I've heard today. I hope it's helpful.
It was very helpful. Thank you very much for cooperation and for your expertise all the time. Це було дуже важливо.
This was super important. Thank you so much. Thank you so much, Ms. Isabel. Thank you for being so engaged in expert assessment. We had that feeling since the very first day, and this is really important to have a reliable shoulder. My gratitude to all our panelists. Thank you, ladies and gentlemen, for staying in Kyiv. Thank you for sharing with us both offline and online. Miss Natalia, I hope I will see you offline someday soon. I will see you someday soon. Okay. So we step into the very last session of the day, and we have just only one speaker, but super important speaker. So, expanding the scale of cervical cancer screening and international experience. Ukraine is the country which is open for any kind of European expertise and experience. Thanks to that, we managed to establish so many systems. We're not superficial about it. This is crucial for us. And I think that we will have a presentation from Ms. Isabel, and then we will draw the line under the event. Okay, so
we hope to hear you. Yeah.
Thank you very much. I will be quite quick because I think you're tired and you've been working so hard today. So next slide, please. This is just, I can't pass the slides. This is, yes, thank you very much. This is just a general document you've seen a lot of time, which is WHO's cervical cancer elimination strategy. The objective is in a few years from now to have 90% of the girls vaccinated, 70% of women being screened, and 90% of screen positive women being treated adequately. So the next slide is just to show that there are still many years with cervical cancer in the WHO European region, and that women screened is very low in some parts of this region, about 11%, but very high in other parts. And only 1/3 of the country have at the moment organized population-based screening programs, but I've heard this morning that you are ready to set up this kind of program. So the next slide, I just want to very quickly to present to you a few information about how to proceed to set up cervical cancer screening. The objective is that women will have health benefit from this cancer. From this screening. So I have divided in different kind of providers. The first is the screening organization. You have one in your country. It's organized population-based screening. This has to be organized, decided by the Ministry of Health, and you have to decide which is the target group. It's already done in your country. You have to invite the women, and the very important point is to communicate the results of the screening, of course, to the women and to the GPs. The next slide shows who is doing what. The GPs, midwife in some countries, and gynecologists may be responsible for the primary process of the screening. Answering questions, providing information, which I called empowering the woman with the knowledge about what is cervical cancer and how it can be prevented, is very important. Then these healthcare providers will be responsible for taking samples and advising and referring women through a very well-defined pathway. And I've heard this afternoon that you have already pathways organized in your country. So this is the task of the GPs, midwife, and gynecologist. Next slide shows what is the tasks of the screening laboratories. It's a huge task, actually. They are chain partners of the sample takers, and they should be contracted by the screening organization. They will be responsible to shipping collection material to sample takers, to the clinics, to the primary healthcare facilities, shipping material collected to the lab, performing cytological or HPV evaluation, and communicating the results to the screening organization. it's very important task. It's kind of the middle of the whole program, and it had to be very well organized and discussed. Then the next slide shows what is the role of the gynecologist. The gynecologist will provide the follow-up examination to women referred from the screening program. They will have to conduct diagnosis testing, colposcopy, mainly colposcopy, and biopsies, of course, and treatment of women, advising of monitoring after treatment, referring patients back to their GPs, and do the most they have to do to have women understand that they have to come back for follow-up after treatment, so that they are not lost, and so we can make sure that the treatment has been efficient and they are treated. So next slide shows that what is the key priorities areas for action, which are well-defined pathways. I already said that, and in such pathways, the population eligible for screening should be identified, invited, and this is what we call organized population-based screening. Then screen-positive women are referred for appropriate diagnosis and treatment, and the outcomes of each case are reported back to the women, to the primary health care facilities, and are reported in a health system information, which I understood is almost ready in your country. So the next slide shows just how it's organized. I like these slides, how it's organized in Holland, because you can see the three phases. The first one on your left is invitation and sampling. The second one in the middle is testing. And the third is diagnosis and treatment. And I like the way it's done because it's easy to understand. This can be shown to the patients before. You will say, here I'm going to do the sampling, then the sample go to the lab, then we will have the diagnosis and treatment if the test is positive. The next slide is now I'm going to say a few words about cytology or HPV tests, so which tests should be used for screening. If you the country is going to, or the country or the oblast is going to use cytology, it's great. But then there are very important quality assessment that is to be done. The lab should have evaluation, regular evaluation. They should look at around 15,000 slides per year, which is a lot. And then it should be in centralized data. And then definitely important of high standard training and education and training, regular training and education for the cytopathologist. You can find on this reference very good presentation of quality assurance for cytopathology. If a lab is going to look at fewer slides, then it should not be used. The lab needs to have regular looking at an amount of slides per year. So the next slides, we already discussed it earlier, and Natalia said it very well. Cytology can miss up to half of existing abnormalities. So that's not the best way of testing, but this is at least what has been used for many years in many countries. The threshold for abnormal cytology is ASCUS, and then you did not discuss at all about liquid-based cytology, which can be used also. It's more sophisticated, but the threshold is also ASCUS, and the threshold to identify the need for further evaluation is ASCUS plus an HPV test positive. This next slide shows you how it works. For instance, in Australia, you see on the left of the slide the incidence of cancer. Then you can see how it decreased after they started to do Pap tests. The next slide shows how it was in UK and in other countries when they started organized cervical cancer screening using Pap tests. You see how the incidence of cancer and mortality decreased sharply after they started to use it. The next slide shows how it works in Slovenia. It's the same. You see Pap test is doing quite well. But in some countries where Pap test is not used and still Romanovsky is used, unfortunately, we do not observe the decrease in incidence of cervical cancer. So it shows that if cytology is used, definitely Papa Nicolaou should be prioritized. The next slide shows what the HPV test. As I said earlier, if you plan to use an HPV test, you may select a clinically validated assay. And then there is necessity to have a secondary non-specific test to triage HPV positive women. Because as we know, around 10% of the women are HPV positive. We know that all of us, we have been HPV positive at some point during our life. We do not all of us have a cancer. So an HPV positive test doesn't mean a cancer. So there is a need for a further triage test. And this has to be decided at national or level. And also it's very important to have quality assurance and efficient referral system so that all HPV positive women are not left in the field and are followed with a diagnostic evaluation. So the benefit, the next slide shows you the benefit and safety of an HPV test for screening. Screening with HPV can be delayed until 30 years, but you know that, and that's what you're doing in your country. And then you can have a test every 10 years, because when the HPV test is negative, the risk of a cancer in the next 10 years is almost zero, less than 1%. HPV test can enable self-sampling. We discussed it a little bit. I just wanted also to add that now we are looking at urine test, HPV test in the urine, which is even more easier, and it looks probably as a good test. Let's see in the coming years. And as you discussed, it breaks barriers to cervical cancer screening, and it's also very important, decrease workload for healthcare providers, because it's a lot to do a cervical cancer screening to the population. It's a lot of work for the population. The last line is just about health information system. The next slide, sorry, health information system. It's mandatory. It's mandatory, and it has to be implemented and validated before you start the program, because it will give quantitative indicators which help to monitor the success of your implementation. And it's mandatory to do that. And definitely you should work on this as you are thinking of implementing the program. So next slide is just to say that today the most commonly used test for triage is cytology. It is liquid-based cytology because the cytology is done on the same sample. You don't need to have the woman coming back. So there is no last for follow-up for this test. It's quite well used in some countries, and you may consider it. The next slide shows you what is triage with cytology in UK. And earlier today we heard of one of you saying we needed to have an algorithm easy to follow up. And I think that this UK algorithm might be very easy to follow up. You have an HPV test, it's negative. Women come back in 5 years, it's positive. Then you do cytology. If cytology is negative, you do another test 1 year after. If cytology is positive, then you do colposcopy. I like this algorithm because it's very easy to understand for everybody. I mean, not only the doctors, but also for the patient. You can show her how it works, and I'm sure she will understand. So the next slide is about implementing a program. The funding is mandatory. Then you have to design which are the diagnosis method. You have to establish quality assurance program, quality management system, and the training of healthcare providers is very important. Appropriate treatment approach need to be implemented. You did not discuss it at all today, but I think it's very interesting. Now people are more and more thinking of thermal ablation and ablative treatment for women HPV positive, and maybe this will be for the next year program to discuss about that. And then just before to finish the next slide, I want again to talk a little bit about appropriate educational initiative. The transition from cytology to HPV presents unique challenge for patients and providers. There is a shift there, from HPV being used as an infection marker to an oncological marker. And this is very important. There is a lot to discuss with women so that they feel no anxiety, no shame when they are informed that they are HPV positive. They just understand that there might be a risk. Just always tell them 10% of women are positive at one time, and we have all been infected with HPV. So there is no way to be ashamed when they are informed about that. And my last slide is just to say once again that, the next one, is it the next one? Yes. The next one is that it's very, very important to destigmatize HPV by emphasizing the highest prevalence, and to explain the women that it's not, don't have a cancer when they are HPV positive, and to explain them that this is not a marker of infection. And I want to insist on that, because many people in my hospital, when a few years ago, I always had some colleagues that would say, oh, you're HPV positive, oh, you've been around, or maybe your husband, or how many partners did you have? We do not have to speak about that. We know now for sure that the infection can be latent for decades in the cervix. And there are women who have been infected in their 20s. They have already been negative, and at the 60, 65 years of age, they become positive. Not because they are restored to have sex, but because they may, but because the HPV infection has been latent, quiet in the basal cells for years. So that's very important, not to stigmatize women who are HPV positive, but just to tell them, well, if you are positive, let's evaluate if there is a precancerous lesion. And that's all for today. Thank you very much.
Maybe there are questions to Isabel? Any questions to Isabel? Despite the fact that it's time to finish according to our agenda, I'll be brief. Can you hear me well, Isabel?
Maybe some questions.
I have one. maybe it will be a little bit primitive, but I can't not to ask. You said that we should move to screening only using test HPV for beginning. Does it mean that cervical cancer can be only because of this virus? So there isn't any another reasons of development of cervical cancer? Thank you.
You're right. You're right. Cervical cancer is only because of persistent HPV infection, persistent for years. Just see, when we are in our 20s, we all get infected. And you know as well as me that the age of cancer is 40, 45, 50. So women who have cancer in their have persistent for 30 years. There is no cancer not related to HPV.
Okay, thank you very much.
Які ще запитання до пані Ізабель?
Any other questions to Isabel?
For your active participation, because it's no questions more. Thank you for your comments, for your commitment to Ukrainian program, for your expertise, and we will now on the period of finishing of the conference, our technical meeting, let's say, technical meeting. Я думаю, що Андрій має...
I think Andriy has to finish this technical meeting right now. Please use the microphone. Isabel, I will ask you one more question, if I may. Could you please tell us, you've worked for so long in post-Soviet countries where they transitioned from pap test Romanovsky-Hinso to pap smear test Papa Nicolau. What were your main challenges to engage doctors to start using the new pap smear test Papa Nicolau, and what recommendations can you give us to implement that in our country? Thank you.
Thank you for this question, Arina. The Romanovsky is cheap, quick to be performed, but very low efficacy at diagnosis cancer. So in post-Sovietic countries where this test is still used, the incidence of cancer is still rising. That's why it's not a good test, because of course you do it quickly, it's cheap, but then the women come back a few years after with the cancer, and the cost of treatment and the workload of treatment, the cancer, and all the life of the woman, the family is destroyed just because you wanted to use a cheap test, which is quickly performed. So that doesn't make sense nowadays that we have efficient tests like Papa Nicolau. You've seen what I've shown you in many countries when they started using it, that the incidence decreased. And now we have another, even more efficient test for screening, which is HPV test. That doesn't make sense to continue to use a test. I've heard this morning a lady saying, "You are lying. You're lying to a woman when you tell her there is no risk of cancer, your Romanovsky is negative." You said that yourself this morning, and I fully agree as a gynecologist with what she said this morning. We are lying when we say to a woman who is Romanovsky negative, no risk of cancer. That's not true. Over.
Так, колеги, я відкриваю свої записи. Що ж, колеги, ми
So, colleagues, we are finishing this meeting. Let me sum up. Let me build the bridge into the future. I think for sure that in half a year, we will meet again in one of the events, because without the World Health Organization or without the World Health Organization, there are still events, conferences, and we have to continue building this dialogue, and we have to continue discussing this topic based on this discussion. From our side, we will collect all the presentations, materials, and share them with you so that you would have access to them, and so that you would look through them again or use them in the future for your reference. And we listened to the pilot project information aimed at capacity assessment, needs assessment, and facilitation of the possibilities and capacity of Cherkasy community region to implement screenings with the resources available in the community. The community didn't get any resources apart from technical support, information campaign, and some political support. We didn't provide them with any additional resources. We didn't procure tests or equipment, although if we had funds, we would gladly do that. That's why this project is so valuable, because the community was using only the available internal resources. Three components of that project were about the needs assessment and the understanding what is the condition and what's done in the community. The second point is about the technical capacity assessment and capacity building of the trainings and the laboratory system. And the third point is the information campaign. The information campaign was conducted among doctors and also with the prospect for the patients to build the adherence to screening and vaccination, and to raise the population's awareness level on the prevention of the cervical cancer, vaccination, and treatment. Well, these three components are the foundation for any community to develop the screening programs in the future if they have the necessary resources. And in the next discussion, we heard that in general the policy is already formulated, developed. So we heard that the policy is there, the standards are there, let's comply with them. Also, we partly discussed topics related to funding. If Mrs. Volodka is here with us online. Natalia Volonko shared the NHSU letter explaining that HPV tests are included in the package, that it's just the facility that chooses to use them or not, and continuing providing the preference to cytological tests, and that is the approach to the cervical cancer screening. This is the old practice. The new practice is HPV testing, and HPV testing is in the package. So how to make HPV testing the first choice tool for the primary health care level when they implement screening programs? Well, we have a lot of question marks in this question. How can we do that? Prioritizing that in the administrative level, popularize and assess, and whether there are enough funds, changing the standard procedures, changing the approaches, and so on and so forth. The discussion is very interesting. Antonina, do you remember when we had the last technical discussion, when in the patient pathways you wrote the referral to cytological testing, or HPV testing, and I offered to change and at first put HPV and then cytological testing. Nothing changes, but at first the doctor will see that the first choice is HPV testing. So the question is very interesting, and in the future we have to make this decision to understand whether we can prioritize HPV as the first choice when we procure the tests within the package of medical guarantees. We didn't work on that very deeply, but this is discussed, and the NHSU promised to officially post the explanation and the information. So, like, they are ready to fund everything. We just need to decide how the processes are organized, the pathways. We advanced here. We have the pathways. We will share them in the presentation. They were developed. I don't know if they were already approved, but this point will be shortly solved, and we will get back to this point, and we will ask Cherkasy how it works in the future, but there are the pathways that can be used for screening. Then we heard a few projects of the experience of Chernihiv and Lviv regions, how the system created the foundation for screenings. But to sum up, for now in Ukraine, we don't have the systemic screening of the cervical cancer, and HPV testing is not used as the priority testing. And if we may simply see some sporadic cases. Primary health care needs support in terms of capacity building and trainings, understanding of how it has to work, and the cooperation with the laboratory service. We need to understand where to send the samples, how to do that. All of that needs administrative effort, coordination, and managerial effort. There was we heard about self-sampling. We have the lack of human resources, nurses. We heard about Chernihiv region where there are only 60%. Like they have the lack of human resources in primary health care by 60%. There were a lot of questions because here we heard about a lot of concerns about self-sampling. It may be there. We didn't learn that because there wasn't a task from MOH and so on, but I think that we will study that as an option. It's there, but probably what I heard is not like the first choice. There are so many risks, and from the very beginning, it means a lot of risks.
Therefore, expertise is super important. And we heard 3 regions today in the panel discussion. What we heard a proposal we heard it from PHC people, how to motivate the doctor, how to increase the interest, how to help, how to become the doctor who can do what the state is expecting from one. You know it perfectly that it's pretty hard to do. But it's not just about stating problems when you find solutions. People are not aware still. Population is well aware now of HPV, of the threat itself, of the risk, and so on. But when it comes to screening, well, we heard that, yes, it's okay with the gynecologists, but not that okay with PHC. Maybe we need to have some focus groups, working with people more, covering more people. Changing attitudes and mentality, this is hard. Our people are progressing radically when it comes to responsibility for one's own health. We now understand that the best position is when you are the one who takes care of yourself. If something happens, treatment itself, yes, but you are able to prevent. You can minimize the risk factors. Not always at work, so this is more for strategic communication, which is the task of the state, and this is the task for international institutions. We spoke of these, let's say, annual examinations. Well, I will not comment upon that, how to work with that. We definitely know that we will not bring this back for all categories. This will not happen. Like, there will be no umbrella approach. We can use these examinations for certain categories of population, not for all, but still, population screening is not about annual examinations, it's a tool. Population screening is about everything. Patient's office, well, we've discussed that. We don't know how that will be implemented, what will it give. There were precautions also, like how to use various questionnaires, surveys, pre-questionnaires. These are interesting ideas, but we heard it from Yevhen when it's self-questioning, basically, yeah, the self-questioning. So we ask people and aggregate the data, make the sample, but this is self-questioning. When it turns into medical information or medical records, only under the doctor's verification. We need to read it and understand if maybe the patient missed something or confused something, or made a mistake. There's no clear answer. I don't even understand myself, how can we do it in future? But we want that to happen for the future. I spoke of this, that this pilot project was not just for the sake of the project. We had some financial limitations, but it's in the interest of European Union and Commission to help Ukraine with more money, to support our healthcare system better. Governments are discussing this. This is not my mandate. This was the prerequisite, actually, for the oncological service to be supported in a broader sense in future by the European Commission and European Union. That we have this oncology tackling plan. This is the only strategic document at the level of EU for fighting NCDs. No other documents are there. For NCDs, this is purely under the oncology tackling plan. So we do hope that our activities will create a foundation for that and will somehow create an impetus to get more funding for capital investment and for technical investment at the level of Ukrainian government. And you, as representatives of medical community and HCFs, will get some support. We'll see. As WHO, we still stick to that. We have the strategy for cervical cancer elimination, a strategic document, which is an umbrella one. We'll push that forward. This is maybe the first meeting where we speak of the third component. We have component number 3, by default, access to high-quality health care. It is guaranteed by the law, but screenings, we discuss it for the first time as a national program. Vaccination is there, we can talk about it, and it doesn't matter how much time we need for that. We'll speak about elimination. So I think that with the charity fund, we'll continue working with you. We'll check with awareness raising campaigns, with PHC, to have the follow-up. And Yevhen shared this idea. Maybe we'll work with NHSU data, available data, in January or February. It's not that we want to assess the whole system, the whole e-health, but we want to see what's there. We had the same with hypertonic disease, and quite relevant data were received there, even considering the fact that not all data are entered. Just to understand how what is entered, to understand the central level. Colleagues, if you want to add something, anything, or just to reflect. But I'm still grateful for you, for your resilience and for your strength and mental stamina, first of all. I'm not very fond of parasitic words, but anyway. You're reflecting for hours already. When you're sitting and listening, what you're doing, you just compare it with your data and conclude. If you have anything else to say, maybe you want to ask us, each other, whatever. Y'all are speakers now. Well, I think that we've dug up the whole agenda. We've recalled everything that we had today. Only words of gratitude, this is what I have. First of all, to WHO team. We were shaping this project with them. So this was basically a marriage based on love, not a marriage by convenience. So my gratitude to Miss Elena, she's just asking questions today, but still. Elena, thank you for your huge technical support, and when it comes to documents, reporting, the link between Ukrainian experts and foreign consultants, you're a very effective agent, I can say. Andrei. So he does a lot for the NCD area. And quite a specific topic of oncology prevention. And you can see that I think that you may have a degree of oncologist. It's somewhere there, even if you don't have the certificate. My gratitude to Cherkasy. I just want to say that this is, it's not that I'm just being polite. I have so many years of experience, but so much openness and enthusiasm is there. You're very open. You're always open to acknowledge that there is some gap or lack of knowledge, but still. And I'm amazed with medical staff. I'm amazed with PhD people. I am. I'm amazed with your professionalism, motivation, and this is really, really amazing for the trainings. It's not because the trainer is great, but we have the continuous education. We're accredited. We have the pre and post training tests, and we had almost 100% coverage when it comes to high quality results, high level results. It means that we have participants with huge practical experience, not theoretical but practical, and a lot of life experience.
And I want to thank my team as well. Although the project is small by volume and time and finance, but people speak about million projects, and we know all of that. But over this period of time, with a small team by the foundation and the WHO, we reached great results, bigger than some big projects get. And people who were working, Katya Hetalo, a great specialist who is an economist, demographer. I'm so proud of the young generation, how smart they are and prospective, and that they stayed in Ukraine. That's the most important thing, that they are here and they keep on working in Ukraine. I want to mention Lisa, who is the coordinator, and she actually organized all the soft components, organization. We had no problem when Lisa joined us. And Valeria Didenko is one of the few specialists on PR. Well, she works with health topics, health sector. She's a journalist, but medicine is the chronic interest, and you'll get back into medicine again, but we don't want to lose this connection. So I want to thank everyone and the team providing the technical support. And also I'd like to say a few words now. I want to say thank you to everyone. I want to join Andrei's words and Halina's words. It was a very difficult pathway. We went to Cherkasy regularly, met everyone. But one more comment about what Andrei said, that at first it's better to write HPV test and then cytology. When we corrected everything with Lydia, we looked into the future and adapted everything to reality. Back then we didn't have any HPV results back there. Right now we have cytology. We will do cytology training. You provided training, Laura provided training, so we did our best. One more point related to the technical aspects. A lot of pictures were taken today. On your badges you have the QR codes. Feel free to scan this QR code, and after 6 p.m. all the pictures will be following that QR code. All the presentations are in the PDF format. Feel free to read them, and thank you, Halina, when the whole team joined. It was awesome to work with you because all our Zoom meetings, working group meetings, it was awesome. Thank you. And I once again want to thank Cherkasy Department of Health that they gave us so much time and attention. It was awesome, but I do hope it's not going to be the end of cervical cancer screening in your region. It's just the beginning. Thank you. Thank you. We hope for that as well. Thank you. Goodbye.
Колеги, я сподіваюся, що всі адміністративні питання
I do hope that all the administrative issues were solved. If you need compensation or whatever, I don't know if anyone stays here for a night, but have a safe way home. If you have to go back home, have a safe evening. To be continued.